Okay, good morning, everybody. Appreciate everybody being here this morning and those joining us by ITV. Just do a quick sound check here. Kent, can you hear us okay? I see Ken on the screen. Can you hear us okay via ITV?
That's 10-4.
Okay, so let's check our volume here. So okay, so we good to go, Kent?
Yeah, can you hear me?
Yeah, we got you now. Very good. Okay, first item of business, I'm going to call the roll. So Allen County, Donnie. Tim Wright. Anderson. Maria Hardy. Dennis Cheney.
Here.
Teresa Hunter.
Here.
Drew Beckett. Brent Blevins. Tony Cox. Here. Dr. Sharp. Breathitt County, Dr. Sharp. Scott Shrewsbury.
Present by ITV.
Okay, Allison Adams. Andrea Renfro. Linda Cabot. Mark Powell.
Here, via TV.
Lynette Renner. Tim Gould.
I don't understand what the...
Okay, somebody left your mic open on ITV. Just give you a warning here. Dr. Leach. Thursa Sloan. Paula. Marcia Hodge. Bobby Ratliff. Noel. Gigi Meredith. Deb Philman.
Here.
Chris Crum.
Here.
Bobby Crider.
Here. ITV.
Denise Beach.
Here on ITV.
Randy Gooch. Russ Briggs. Karen Cooper.
Here.
Susan Lyford. Sean.
Here.
Mark Hensley. Debbie Miller, Lawrence County.
Present. Cindy's sitting in for her.
Lewis County, Anita Bertram. Sarah Best, Lincoln Trail.
Well, here, ITV.
Okay, Paula Thornberry, Little Sandy.
Here.
Louisville Metro, Dr. Nesbitt. Got Ryan. Okay. Nancy Crew, Madison County.
Here.
Pete Shepard, McGoffin. Tina McCormick. Steve Ward. Kathy Crown Weber.
Here, ITV.
Jill Ford.
Here.
Jan Chamness.
I'm here, ITV.
Rebecca Keith.
Here. ITV.
Renee Blair. Dr. Lynn Sadler, Northern Kentucky.
Here.
Teresa Gamsky. Allison Bashir.
Here.
Dr. Rangel, Pike County. Kathy Neal, Powell. Kent, I know you're there. Georgia. Jen Harris, Crystal. Gail Temperio, Whitley. Melissa Royce. Okay. Thank you all. First item on the agenda is the meeting minutes of the prior meeting went out via email. Are there any corrections or additions to the meeting minutes? May I have a motion for approval, please? Okay, who made the motion? Grandy Gooch, and seconded by Allison. Any further discussion? All those in favor so state by saying aye. Opposed, nay. Okay, minutes stand approved. Treasurer's report, Crystal.
Okay, for July 2013 to February, for the KHDA account, we have a total income of $72,175, total expenses of $74,920, which leaves us a deficit of about $2,700. That's just due to some health departments paid their dues earlier, so they were accounted for in the last fiscal year, so we're fine in that account. The KHDA and KPHA joint account, same time period, total income $86,373, total expenses $71,020, which leaves us about $15,353.
Okay. Okay, we have a motion by Paula for approval. May I have a second? Seconded Russ. Okay. Any further discussion? All those in favor so state by saying aye. Opposed, nay. Okay. Treasurer's report accepted as presented. Thank you. Executive Director's report, Steve.
As always, I mailed it out yesterday morning, I think it was. And so I'll be glad to take questions about anything that was in it or take questions about anything that wasn't in it. Beyond that, I don't have anything additional to report. I guess I would elaborate a tad on the legislature, although I think we'll probably discuss it a little bit later, which is that's obviously moving sort of fast and furiously as we move to the end of the session, and we did. Randy sent out an update yesterday. I think it's pretty fair to say that it would be bizarre, but not impossible, for something that has not been introduced and not had progress in one of the chambers to be introduced these last couple of weeks and have anything happen to it, unless it comes in as an amendment to another bill in the closing days, and I'll just do the best I can to be watching for that. I think there is a legislative report on the agenda there. So we'll go into that further. I don't have anything else, and I'd just be glad to take questions.
Okay, any questions for Steve?
This is Lynn Sadler, Northern Kentucky. I don't have a question. I just have I guess a couple of comments. And I just wanted to share with everyone, I know Steve alluded to it in his report, that he mentored me and worked with me on a House Bill 339, which was an amendment to
I know she was going to say something about it. Come on back, Dr. Sadler.
Lynn, we've lost you there. I don't know if you can. I was afraid of this. Yeah. Okay. Yeah. A little bit better. So come back again there.
Okay, so Steve and I got to spend a few days together as he helped me try to shepherd this thing through to get it heard by the House Health and Welfare Committee. And I learned a tremendous amount from Steve. If you don't know how to do advocacy work, he would be a tremendous mentor to work with for a few days. And I look forward to spending more time with him. I feel like I learned more from him in just a few days than I have in my entire career. So I want to thank Steve publicly in this meeting for all his help and his work on this.
Thank you very much. We didn't get the bill through this session, but we have set the stage for next session. So thank you. Dr. Sadler was great working with the legislators too.
And thank you, Steve. I appreciate those comments there, Lynn, bringing those forward. I think, this session has been an extremely busy session. And as we segue here to the executive director's report here, or the executive committee report, that was one of the first things we talked about was legislation yesterday at the executive committee, and it's pretty much been predominantly the focus of what we've been doing here the past couple of months. We've had a very active session. The budget has really consumed a lot. Smoke-free has been so busy, and as I'm sure most people have seen the reports and everything right now, the smoke-free legislation. Worked very hard on that. A lot of our great partners has worked hard, the State Chamber of Commerce, American Heart, American Lung, American Cancer Society, Smoke-Free Kentucky. But barring something miraculous occurring at this point, that bill is dead for this session. It's as you're working in the legislative process, lots of things can happen, and momentum can shift very quickly, and we saw that this session. I think it really came through very strong on the smoke-free legislation. The budget, last Thursday, if you like political theater, last Thursday was one of the most animated House floor sessions I've seen in quite a while. The Minority Leader, Jeff Hoover, Representative John Will Stacy, there was a great exchange there that went on, and if you can see it on KET on the archives, but because a lot of us were over in the super utilizers meeting that Thursday, some of us were, and the session was going on at the same time, and I was multitasking, I'll confess here. I was, while I was listening to the speakers at the super utilizers meeting out of one ear, I was watching the legislative floor session on my iPhone with the earbud on the other ear, trying to keep up with what was going on. The budget that was passed, that came out of the House, it continued to have our funding for our retirement increase that we're expecting, so that was fully funded as in the governor's budget. The PVA fee that has come up, that was in the governor's budget, the executive budget, give credit to the Library Association and all of you all who have rallied around this issue, and Steve, his hard work on the halls of the Capitol over there. We were able to get the PVA fee. The legislators have said that they would not support that in the House, and so the PVA fee being assessed on all special taxing districts except schools has been eliminated from the budget that is going to the Senate now. So we won that battle, and remember that this is just one battle in the process. Okay, it is a marathon, so we won that leg of it. The Appropriations and Revenue Committee then had to find the money for the PVAs. And so, not surprisingly, they took part of the allocations we were going to be receiving in the hands of the McVee expansion. As we've reviewed the budget there, we've looked at that. There was funds in the executive budget to replace the federal funds if those are not reappropriated. And then there were funds to expand the multi-gravita hands program to all counties. Well, the funds for the expansion is what was taken out of our budget. So that was removed from our budget as well, there to help to plug other holes and give money back to the PVAs. So again, we came out a winner on the retirement contribution, a winner on the PVA issue, and then we just lost expansion dollars. And we have to take a step back and remember that most other agencies in the state are taking a 5% cut this year, and we just lost money that was going to go for expansion of programs, not existing programs. So very good there. Now, but we do have to take a step back and remember that in the budget that was approved, $6 million the first year, and correct me if I'm wrong on this, Randy, but $6 million the first year and $11 million the second year are dollars that have been switched from general fund dollars to restricted dollars, and that those dollars were expected to earn those from savings from the Affordable Care Act. So basically, they're anticipating that $6 million worth in the next budget year, there, the FY15, that will be able to replace dollars that we've been using general fund dollars with $6 million of billings from the MCOs and Medicaid. And the second year, $11 million, because more people are going to have insurance. So they've already anticipated that. I think Steve Shannon, with the executive director of the Mental Health Association there, they said one way to look at this is that we've taken guaranteed dollars and we've replaced them with assumed dollars. So, these were hard dollars that have been removed from our budget and replaced with dollars that's being assumed we're going to be able to earn them. So
this year's general fund allocation will be $14 million and not 20.
we don't know that yet. So
Is that
We're assuming that it will be.
we're assuming the public health block grant, but then DPH is going to have to tell us how that all, will pan out there. Yeah. So, but I think that's a safe assumption that the block grant will be reduced. But then the other side of that is the $14 million in retirement is going to be allocated based upon our payroll and staff. So they're going to be, they're as this comes down to DPH, they're going to be given guidance as to how that money will be divided out based upon the number of employees and our payroll. So, we're looking at that money coming down. So, again, it is not a windfall for us by no means. But everybody that I've talked to and some others here that have worked the process here can say, I've been told this is the best we could have possibly hoped for this session, that we're coming out really good. That's one of the reasons why our strategy now on these replacement McVie dollars, yes, we would like to see that restored in the Senate budget. However, we don't want to appear too self-serving and greedy and saying, hey, we're getting this other, we've come out on the plus side on all this, we still want more. So strategy here, I've been in discussion with Cindy Heine with the Pritchard Committee about letting them really take the lead on advocacy to restore money for early childhood home visitation programs, and which they are doing. But the flip side, too, is if we don't ask, we know we'll never get it. So you use your judgment with your senators, and now's the time we need to focus really on the Senate with what that comes out of their budget here now, because they'll pass a budget and then it'll go back to conference committee. So we need to switch our focus to our senators now, make sure we're having conversations with our senators and that they continue to pass our retirement funding, that they also, too, understand the PVA fee. I did a presentation to Senate Appropriations Revenue, Bob Leapers, Senator Stan Humphreys, Senator Robin Webb, Senator Walter Blevins. Several of those senators had very positive things to say about health departments, and they were not in support of the PVA fee. So I left that day there feeling very positive with the Senate. I talked to Senate Minority Leader R.J. Palmer last Friday night at a function in Clark County, and he was very much on our side with this issue, and I stressed the importance of the retirement funding for us, and that we'd like to see the budget as it's coming relating to public health passed just straight down the line by the Senate as it impacts us. So use your judgment. I've had several people respond that they found it very helpful the previous language I sent out to do a letter to your representatives before, and so they've asked that I'll do another, just a sample. So again, I will draft that later this week, send that out to everyone. It is for your use only if you so choose. If you do not, many of you are as well versed or better versed than I am on this stuff. You know how to talk to your legislators. So you take your approach and do, but I will provide sample language for everyone so we're all on the same page if you so choose to use those talking points. Okay? So that's kind of where we stand right now with the budget, with smoke-free. You know, some of the other bills, you know, we've been watching those, and a lot of the other bills, like Senate Bill 88, that was to restrict Board of Health, is not getting any traction, not even made out of committee. And so, you know, there's a lot of other bills there that we're watching, but there's not a lot of movement on right now. So that's pretty much where we're at. I know Randy and Allison heads up our legislative committee. Do you have anything additional to add, or Steve, anything about legislation? Any questions for any of us?
I would say, I think the date is April 29th. I'll double check that, but I think we sent you all an invitation that from UK's, I forget what it was called, their smoke-free thing that Dr. Hahn and others are
Kentucky
involved
Center
with.
for Smoke-Free
Kentucky
Policy,
Center for
yeah,
Smoke-Free
spring
Policy.
conference.
And that conference on April 29th, I mean, I would say that if you are really interested in smoke-free, you want to hear and have input into the strategy for the next 2 years of how to turn this thing around, or the next year till there's either a short session or a special session or whatever. I think there'll be a lot of discussion at that meeting on the 29th in Lexington at the Doubletree Inn. And so I would encourage your attendance if you'd like to learn more, if you want to learn more about e-cigarettes, and because there were several bills about e-cigarettes this time, and that's going to be a big issue in the future, regardless of what happens on traditional cigarettes. So I'll just urge you to attend that if you want to be part of trying to change the smoke-free thing.
I just want to thank all y'all for being so diligent and spending so much time advocating on behalf of all the Thank you.
Thanks, Noel.
I don't really have anything else to add. You did a good job covering most all of that stuff, but other than just to kind of reiterate what Dr. Sadler did, and I think the folks that don't really get, visit the Capitol much and see Steve in action. Steve's got a lot of contacts there, and he's there every day and has done an excellent job for us, just advocating, for our positions on things, and trying to make sure that we're recognized and that those legislators know who we are.
And that's, for years, a lot of us have been around a while. We always complained that health departments were the best kept secret in Kentucky. Well, folks, we're no longer a secret. People know us, and there's a bullseye on our backs. Okay? It's just, we're highly visible right now. Yeah, the pendulum has swung. But I have been so pleased to hear such positive comments about health departments, our issues, our concerns, and this all comes from the local level. Your relationships, as we look at assessment, assurance, and policy development, that first step in policy development is cultivating good relationships with the people that make policy. And when it comes time for a session, we've often heard a legislator who said to us several times, well, I just don't want to see you when you want something. They want to see us all the time. You have to, part of being the job as a director, from my perspective, is going to those Friday night events for the YMCA where your local senator is going to be and all this stuff, because you cultivate those relationships, over in an informal setting, that then when you do need something, you've got a good relationship there to go and ask for it. So I think, it's very important, and just, again, appreciate all the work. I give all the credit to all of you all out across the state, because I'm hearing it as we're interacting with the legislators in the halls, that's where we hear back the positive things about health departments, and that comes from the local level. So, again, thanks to everyone and on the work so far. The work's not done. We can't lay down now. Anything can happen. As the old saying is, we don't sleep until the legislature adjourns. April 15th, Sendai, that's the day we look forward to when they're out of town then, and in the next 2 years we can get back and focus on what we need to do. Really, we have to work. We have to work our senators and make sure that this budget stays intact for us to help us as we move forward. So again, thanks to everyone.
Mr. Rice, can I make a quick comment?
Sure, Rice.
I used to spend a lot of time wandering the halls of the legislature, and I hadn't been over there on behalf of public health in a long time because most of what's on the aggregate agenda doesn't have a lot to do with Lexington, and it may not have as much to do with some of the other places. And the point in bringing that up is, as we go forward, I think we really need to give some thought to what we want to look like 2, 4, 6 years out, and not so much where the money's coming from, because there's some things that showed up in that strategic plan that have been there for years and years and years, and it seems to me that's our long-term calling, and somehow that message has got to get out to the General Assembly along with the money troubles. Enough said. No,
and
it's something we can add to what we're currently doing, and I think in the long haul will be useful.
Allison.
One other thing to just say is that Randy and I, as the legislative committee co-chairs, we want to keep this committee going year round so that we can start using our strategic plan and start attending, the out of session meetings and things that we can keep in the forefront, not just while we're in session. So hopefully, when we get our strategic plan together, we'll have something to go and educate them with, instead of just following that money.
And I think your perfect segue is what else we talked about yesterday in executive committee. Instead of the tail wagging the dog and the money, directing this, I think that's part of the whole strategic planning process we're going to be talking about later today with Georgia, about making the case for what we should be doing in public health, how we can really make an improvement in health status in this Commonwealth, and why we are of value to the legislature and why they should fund us to do what we need to do. So I think that working on that. Another thing is about policymaker education and education for us. We talked about the Foundation for a Healthy Kentucky RFP yesterday, and we're working on that proposal with the University of Kentucky, the Public Health Institute there, as well as partners reaching out to the Kentucky Chamber of Commerce. The current strategy that we have talked about was trying to do a series of policymaker forums across the state, really working to educate policymaker forums on health and all policies. And so we're looking at strategies right now to apply for this funding through the foundation because it's directed towards public health policy development. And so how can we, change public health policy? How can we support that? The Friedel Committee has already pledged their support to whatever we want to do. Partnering with KPHA, the University of Kentucky, the University of Louisville, our other regional universities, the Chamber, and looking at this. So we're working out strategies there to do an application on that RFP. And I know there's some others interested in that. So we'll, as that moves a little bit farther along, we'll send out some more information about that. And then another thing we discussed yesterday was our bylaws. We are looking at revising the CADA bylaws to be more inclusive. So Deb Philman, do you want to talk for just a minute there about what the bylaws committee is doing? I think you're heading that up for us. So.
Sure. Thanks, Scott. Can you all hear me okay?
Yes.
Okay. We have a bylaws committee that consists of myself, Crystal Cottle-Miller, and Randy Gooch, and the three of us took the bylaws, and bylaws in every organization ought to be reviewed every so often. And so we have looked at these, and some of the things were just basically cleaning up the formatting and typos and so forth. But there were other areas that really, as Scott said, is just to get it in line to what we've talked about with our strategic planning efforts and our legislative efforts and so forth, and get this organization ready for the next 2, 4, 6 years down the road. So these are going to be sent out to you, to all directors via email, and some specific areas that if you all would pay really close attention to, Article 3, which is the purpose of our association, and we've really done some wordsmithing on that to again get it in line with our strategic planning efforts and just public health efforts in general. So look at Article 3, the purpose. In addition, if you all would look at Article 4, which is the definition, and we've looked at adding those, we've had some talks about there are really 3 different types of health departments in our state. We have the single county, we have the districts, and we have the independents. And to make our bylaws more in line to how we are functioning at present. So if you would look at that language as well. And then we just shored up some language on the treasurer and what the treasurer's functions are and working with the staff, as well as adding some language about the legislative committee, and if there's not, if a past, how it is now, the past president's the chairman, but if that's not available, who would be chairman of that? So again, these are just some of the highlights of what the changes are in the bylaws. You should get those hopefully this week, and then if you'll review those, then we can look for a vote at the next KHDA meeting.
Okay, thanks, Deb, and thanks to the committee members here. Again, the bylaws just trying to really get us lined up here as we move forward, so greatly appreciate that. Other thing from the executive committee, talking about the retreat, for the director's retreat this October, save the date, October 22nd, 23rd, and 24th, Kentucky Dam Village. So we're looking forward to that retreat. Jen Harris is heading up that committee, and I know they're working diligently on that. So just to save the date right now, October 22nd, 23rd, and 24th, Kentucky Dam Village will be our director's fall informational conference. So anything you want to add, Jen, on that?
No, our next meeting is the first part of April, so we'll have more information coming up.
Okay, thank you so much. Okay, then. That pretty much is the wrap from the executive committee. Main things we discussed there. And moving forward with our agenda here, always a pleasure to have a friend of public health here, Mr. Lee Ricketts with Santa Fe Pasteur, is going to talk to us a little bit. So, yeah, come on up here, Lee, and up at the podium, and or wherever you're comfortable.
Are we running short on time?
No, you're good. You're good.
Okay. Good. Morning, everybody. A couple things. I sent some signing sheets around for the food. If you guys wouldn't mind signing those. If you haven't signed one, please do, just to keep me out of jail. Thank you to Scott and Andrea for coordinating the Kentucky Flu Coalition contract this year and cascading any information that went around. I appreciate the help that you guys give me. That's great. 2 things I wanted to talk about very quickly today. The first thing is the new quadrivalent vaccine. So I realize it was available last year, but it's going to be a lot more prevalent this year. So the quadrivalent vaccine is available on the Kentucky contract in essentially every presentation apart from the high-dose vaccine, which I'll get to the high-dose vaccine. The medical rationale for the quadrivalent vaccine is it's an additional B strain. So traditionally in the last decade, they've juggled or changed between 2 B strains, they being the WHO. And what they've done is guess wrong 50% of the time. So obviously when you guess wrong, there's a much higher chance that you're going to catch influenza, even if you get the influenza vaccine. So by including the B strain, they hope to reduce the incidence of influenza. The CDC did some studies. They looked between 1999 and 2009. And they estimated that if they would have included both B strains in the vaccine, if it would have been in that trivalent vaccine for those 10 years, they would have reduced the number of influenza cases by 2.7 million, They would have reduced the number of hospitalizations by 21,000, and more importantly, they would have reduced the number of influenza-related deaths by 1,400. So by including the additional B strain, we hope to reduce, the morbidity and mortality associated with influenza. So there is a medical rationale behind why we're moving forward with that quadrivalent vaccine. So it's available through the VFC program, and it's also available on the Kentucky flu zone contract. So if you wanted consistency there, it would be a good choice to choose for your standard vaccine the quadrivalent option. And I know a number of you have done that at this point, so I appreciate that. The second thing I wanted to talk about is the high dose vaccine. So if unless anybody's not aware of this, the high dose vaccine is for over 65s. It contains 4 times the antigen of the standard dose vaccine. So the normal influenza vaccine contains 15 micrograms of antigen for each strain. The high dose vaccine contains 60 micrograms. And what we've found is that the standard vaccine just doesn't work well in the over 65 population. If you recall, last year the CDC sent out communication about how poorly the standard vaccine worked. And in the over 65 population, specifically for the H3N2 strain, which is a particularly virulent strain for the older population, they estimated the effectiveness to be 19%, which obviously, we know vaccines very well, and 19% is not a good success rate when it comes to protection against influenza. So the high dose vaccine generates higher antibodies, which should help protect you against influenza if you come into contact with it. And we know the majority of pain and suffering from influenza comes in that older population. 90% of hospitalizations are in the over 65 population. The majority of deaths also fall in the older population as well. So it's very important that that population get the best protection that you possibly can. Now, one thing I would say is I would commend the Kentucky Health Departments in terms of their adoption to this point of the high dose vaccine. The majority of health departments that I talk to use high dose as the standard of care, and you guys should really pat yourselves on the back for that. I did a comparison nationally against public health customers that were using high dose and Kentucky health departments using high dose. The national average for adoption of high dose is 10%. So 10% of all possible adult doses are in the form of high dose. The Kentucky health departments are double that. So at least 20% of all adult doses, flu doses that are used in the Kentucky health departments are in the form of high dose. And that's a wonderful thing that you guys have adopted that and are using that as a standard of care. So please, for those that aren't using it, if you have any questions, Scott can provide my contact information. I'm happy to come out and talk to you guys face to face, go through some more information, clinical information that would help convince you that it is the right thing to do to be using that high dose vaccine, because the standard vaccine just doesn't work well enough. For the health departments that are using VaxCare, both the quadrivalent and the high dose vaccine will be available. So obviously for those of you, and I think there are about a third of the health departments that are using VaxCare currently, those vaccines will also be available. So there should be consistency whether you're using VaxCare or buying the vaccine directly from us. The deadline for confirmations, this is one of the reasons I wanted to talk to you guys, is March 31st. So please confirm your order by March 31st. It's a Monday. I think it's the first Monday of spring break. A number of you have already confirmed, but please by the end of next week, hopefully, confirm your order. If you need me to confirm it, just shoot me an email or call my cell phone. I can do that very quickly. Even if you don't know exactly what it is that you're going to order, get the confirmation in and we can make adjustments past that confirmation date. But we just need to get that initial confirmation into the system. Any questions on the quadrivalent vaccine or the high-dose vaccine while I'm here?
Pricing been established for next year?
Yeah, pricing's been established. We could resend the contract out. Yeah, maybe I'll shoot you an email today that you could possibly forward on. Just reminding folks that March 31st is the date, and it will include the pricing in there. There's a one-page summary that we can send out for you guys. Anything else? Just a couple things related to pricing. So both of the vaccines, the quadrivalent and the high dose, have their own CPT code. And so for the health departments that are getting reimbursed, whether it's by Medicaid Part B for Medicare Part B for the high-dose vaccine, or whatever health insurance that you get reimbursed for the standard vaccine, they are reimbursed at a relative rate related to the actual initial outlay of the cost of the vaccine. So you wouldn't be reimbursed the standard dose vaccine reimbursement for the high-dose vaccine. The other thing to remember is that Sanofi, for those customers that buy direct, Sanofi Pasteur has a 25% returns policy. So we know that every flu season is different. If you've seen one flu season, you've seen one flu season. And so having that 25% returns capability allows you that flexibility to kind of, hedge your bets on if you think that the demand will be high or the demand will be relatively low. And I know a number of you guys have used that on a regular basis, and you get full credit for the doses that go back. Any other questions on quadrivalent or high-dose vaccine? I hope that you guys will all adopt quadrivalent. If some of you guys have confirmed trivalent to this point, and you could think about the medical advantage of confirming quadrivalent, that would be appreciated. Anything else? Hope you guys enjoyed the food for the ones that are here. Yes? Yeah, we fully expect that. In fact, Tammy, we submitted a reimbursement. We have a pricing and reimbursement hotline that we can use, and I submitted a request for Tammy to look into. Do you remember what it was? It was WellCare. Several MCOs we're looking into just to confirm that reimbursement. So once that's done, I'll work with Tammy and maybe we can get it out to everybody so that we can confirm that will place. But yes, we fully expect that not to be an issue, especially since this is the second year. So sometimes they're a little slow to adopt, as we know, but last year was the first year. Even though we were late with the licensure for quadrivalent, this is the second year for quadrivalent. So it shouldn't be new to any of those MCOs, because a lot of the private customers used it last year as well. Anything else? All right. Were you doing a song and dance behind me when I was?
Absolutely.
All right.
Shadow puppets up here. So.
Thanks, guys.
Thanks, Lee. Yeah, we appreciate the breakfast for sure. Thank you, and always your great information.
Scott, I'm sorry. I have some coding and billing sheets that I'll leave on the front there if anybody wants to pick these up for the flu vaccine.
Okay. Okay, and any questions or anything you need from Lee, don't hesitate. Let me just give a shout out to Andrea here. We really appreciate her heading up the flu coalition for us and doing all that. So thank you very much. And any way we can be of assistance, don't hesitate to email myself or Andrea, and we can make sure that you're in contact with Lee. So, okay. Okay, next item on the agenda. We appreciate everyone who took part in the start of our strategic planning process. This is an ongoing process, so don't think by any means that we have done our bit with strategic planning here. So I'm going to turn it over to Georgia now and to do her presentation on strategic planning. This presentation went out this morning, so it's in your email that she's going to be going over right now.
All right, good morning. I sent you 3 documents this morning. One was kind of a narrative overview of the day that we spent when we did our fishbone diagrams and all the sticky notes. The other was the PowerPoint that I'm getting ready to show you right now. Those of you that already seen this, I'm sorry, you're going to get to see it again. But I did add a slide that we're going to talk about at the end. And I also sent you a work plan. That work plan is a very sparse Excel spreadsheet that we are going to build upon and build upon and build upon. Okay, so we have a purpose. Why do we do this? I think it's pretty clear to everybody now that without a strategic plan, without showing that we work together and that we are actually using some kind of systematic thinking process, that we're going to get nowhere with our legislators or anybody else. So we came up with 3 overarching goals, and this didn't happen the sticky note day. This was a couple sessions of CADA leading up to that day. And we have these 3 overarching goals, which I think are very important. Improve health status, because that's why we're here. Not for that. There's no reason for us. Looking at our statutes, do they support that goal? And where's the money gonna come from? So I feel like we can all agree that there's a lot of room for improvement with these three things. Our health status is about as bad as it could get. Our statutes are as confusing as they could possibly be, and possibly not representative to what we're supposed to be doing either. And then our money is where? Okay, so we came in here that day, those of you that were here or watching on TV, we came in here, we had some ground rules. Rolania Rice got up and told us how to behave during the meeting, and everybody did do that for the most part. We had a parking lot. For one, Drew had me in the parking lot for a minute when we were doing that day. But we did have some things on the parking lot that later we came back and put on the worksheet that you got. We worked with different sticky notes. They got assigned a meaning. Blue was neutral, pink, red was problem, green, go was the solution. So if you remember, we had the fish all over the room. We had sticky notes everywhere. We had one fish for each of our overarching goals. And here's what we came up with for each of our fish. The fish that was health status, these are the things that were identified as causing that. We do not use a data-driven approach. Our socioeconomic status is a huge problem. The culture of our population in Kentucky, we like bourbon and fried chicken and cigarettes too, apparently. Our organizational culture, it changes hard. And there has been history of doing things differently than how we're doing them right now. Our policy does not connect to our health status currently. It's kind of siloed. And then population health, we don't really have a support system. We're not really going toward that in the way we fund things or the way we ask for funding. So from the health status, let's go to the statutes. We don't understand that. Thursa Sloan, hey Thursa, she went on and on about we don't understand them, and I did not understand either what she was talking about. So I feel for sure that we do not understand the statutes, and at the very least, if we do understand them, we don't agree probably. And then they're pretty vague because shall and may, everybody in the room can interpret those things somewhat differently, and then some of them are outdated in terms of they cause us to do things that the technology is leaps and bounds ahead of now, and we're still back to using pencil and paper for some stuff, so they're outdated for sure. And a lot of them are out there with no money. So do this, but we're not going to pay you to do it. And then the funding. Much issue around the federal grant process and where our health department's in that with DPH. And by the way, I did this presentation to DPH's management team meeting a week or two ago, so they've heard all this. I took my gun and everything. So if you need to know about that gun, I can talk to you about it later. We talked about hiring a lawyer and money and DPH expectations don't go together. The governor, in a timely fashion, with our strategic plan, or maybe I should say our strategic plan, is lining up with his stuff, put his first, our support. That we need to focus on what it is we're trying to change, and change it instead of just being all over the board. Medicaid match continues to be an issue, and then our ballooning packages of the retirement and the insurance and all that, and how expensive that is. So then, after we came to some kind of consensus about what we thought were problems. We did the prioritization matrix, which is we consolidated the sticky notes and tried to determine which ones we could do high impact, low speed and cost to implement. So here's where we want to be, up in 1 and 2. If it doesn't cost a whole lot and it's easy to implement, you can get high impact. That's what we want to do. However, a lot of the stuff that's going to give us the highest impact is going to cost a lot, and it is going to take time and energy and probably some difficulty to implement. So probably our most important things are going to be right here. And then these things might be easy, but they're not going to have that much impact. So Here's just some pictures of people who were here that day. Some of my staff went out on the internet looking for pictures of y'all. Some of y'all got some alternate egos up there. Well, people with your same name, I'll say that. All right, so our work plan looks like this. It takes each of our overarching goals, puts it here, then we have objectives of what we found to be those most important things, and then here is what the individual sticky notes said. So if there's a line up here that's a strategy, somebody wrote it on a sticky note, and I carried it back to Three Rivers and put it in this spreadsheet. So if there's something up there that you feel like, wherever you are out there, that your sticky note is not being represented clearly or the way it's supposed to be, for sure let me know and I will change that. Over here is how it ranked in the matrix, if we felt it was a 1 or a 2 in terms of how difficult it would be to implement and how much of an impact it would be. So you have this, you should have gotten a handout if you're sitting in the room, and if you're not, you should have it on your email. So we have one for each of our 3 goals. So improve health status, statutes to make that happen, and money to make that happen. So those 3 are pretty easy. So the funding, all over the place right now. Here are things that came up. These should be bells and whistles going off. These things came up in all 3 of our overarching goals. Data-driven and evidence-based approach to everything we do, including how do we pay for it. The foundational services, and what are they? What should we actually be doing? So Dr. Leach brought that up earlier when he said, look, what's out in the future? So what is it we should be doing? Let's think beyond this second and look a few years out. What is it we need to be doing, and how are we going to pay for that? What does it even cost? Do we know? Have 2 students. Just one is mine, Pranav Rain. He's here. He is working on a, raise your hand. I've already embarrassed him a lot, so he's good with it. He's working on the funding methodology and laying some of the groundwork for some things that we're going to be needing to carry forth with this as we go along. And then Drew has a student too. I don't know him. You want to introduce him, Drew?
Rob West.
All right. So we may drag him into it too. All right, so we need to know what we're supposed to be doing and what it's going to cost before we'll even be able to go to legislators and intelligently ask them for the money to do what it is. So we need to make sure our funding goes along with what is it we're supposed to be doing. You know, there's some things that there might be funding for that's not the right thing. We don't want to be doing that. We want to do this other thing that'll actually make a difference. And then we want to get along with DPH, important. DPH. When they were there that day, I mean, when we were in their house that day, they definitely agreed to this. They do want to, they know this is important too. They want to be a part of it, and we all are going to have to work together. And then our statutes and regulations are going to have to reflect this. All right, so what are we doing now? We got to go forth and flesh this out and make it happen. It cannot stop now. That day of sticky notes was not, I didn't do that for it. Just nothing, and I know that the people that were involved in it, even more than me, want to make sure that it was something that's going to propel us into the future where we need to go. And the point I wanted to make here, these are my staff that had a lot to do with this too. They were the ones that looked up all y'all's pictures. But I think it's going to take more than just the directors, of course. So here's where we go from now. This is my proposal. So we need actually people to sign up for groups now. We need to get some things done, and we need to report on this at every CADA meeting. So our strategic planning committee will leave here today with some dates when we will meet, and we will provide groundwork to help everybody else get going. But if you look at this structure, here we are, and then we have executive committee over here, then we have all of our standing committees. I only put up the ones up there that I think I have been on at one time or another. I know there's more than that, so I can probably make that look better. But let's have committees, a committee that represents each of our overarching goals. Let's have the committees be made up of the chairs of these work groups. These work groups are each of the main topics, the objectives in our plan here. So what I need is people who are interested in these things to send me an email and say, I want to be on that group. And those people do not have to be directors. Reason being, there are people out there who know more about this stuff than some of us. So they can be subject matter experts and help with that. And they can also be some DPH people. DPH wants to be involved. I told them they could start being involved now. So we would like to get some of them to be involved. And probably some legislators would be really good if we could get some of them involved. So it would be nice to have the people who write the laws, the people who have the money, and then those of us that do the work. If we could all get involved at this level, then we can make sure these things happen. All right, so I need you to send me an email and attach your name or one of your employees' names or a whole bunch of names to these different things. Or if you want to send me an email that says you got that sticky note wrong or something, anything that you want to see happen, have change, comments you want to make, now's the time. And I will say now's the time, and very nicely behind it say, or forever hold your peace. So here's your opportunity to get involved. We are going forward with this. Good, bad, or ugly, CADA is going to have a strategic plan, and we are going to put it in everybody's face. So you want to be involved in that. If you work in public health in Kentucky, you want your name on here somewhere. You want to have a say. Even if you think it was terrible, you need to come up here then and change it. So if you think that this is all wrong, don't say, I'm not going to do it, I'm not going to have anything to do with it, it's bad. Come in here and change it. So that's what needs to happen. All right. Amen.
Amen. Hey, Georgia? Georgia,
Yeah.
Great presentation. The presentation that you sent out by your email didn't include the proposed structure. Can you send that back out?
I can do it. That was an epiphany that I had in the middle of the night. That last one. That last night. Okay. Sure.
Thank you.
Okay. Thanks, Georgia. And this entire committee, this has been a shared effort. A lot of people have worked very hard on this. You know, Georgia, Allison, Jennifer, Drew, Randy, so many people have put in a lot of time with this. So frequently, and I will echo something here, all the time here since I've taken over as president of CADA, I've asked and tried to make sure everyone has had a voice and tried to engage people. Here is the opportunity. If you do not agree with what CADA is doing and how we are approaching things, now's the time. This is the time as an organization. CADA is bigger than any one, two of us. It is about, how we can work together, how we can try to come together and unite and represent what needs to occur and move it forward. So this is the time to get engaged, get involved. Let's make a difference. As the old saying, don't curse the darkness, let's light some candles. And let's do something to make it better. We're always open and welcome to suggestions, as part of the group process. None of us are going to get our way all the time. I've tried for years to do that, and it don't happen for me. I'd like to have my way, but it just don't work out. So we have to compromise. It's about what the compromises that we make for the benefit of all of us and how we work together and having open, honest communication and dialogue. There are other people out there that we're engaging now. We're having dialogue with, the Friedel Committee, just to name one, other entities. If we don't determine our own direction, other people will determine it for us. Is that a fair statement? So we have the opportunity to engage partners to determine what we want to be, how we want to move forward, and to educate policymakers about that. If we do not define ourselves, others will define us and will dictate to us what we do. And I don't think we want to be in that situation. So we have the process, get engaged, pick what you want to be involved with. We'll be engaging other people because this is very overarching here, and we'll be trying to engage others outside of CADA, with this. Our university partners, our academic partners are so important, and the Friedel Committee, Lee Todd, Al Cross. Those people command great respect across the Commonwealth, and we can say something all day long, but when Lee Todd says it, it comes across very differently than whenever I get up, or Russ, or Georgia, or any of us says it. It's seen as self-serving. But when a Lee Todd gets up and says something, it gives credibility to it all of a sudden. So we have some great people who are very interested now. The governor's Kentucky Health Now initiative, we have a focus on health. We can sit back and say, well, here we are. The governor's come up with some great ideas, but he ain't giving us the money. Just pooey on the governor. We can say that, or we can say, hey, we've got a focus on health. How do we make this work? How do we come together? How do we leverage resources? How do we make a difference? So, okay. So, again, I'm off my soapbox now. Please get engaged, get involved. Everyone's opinion matters. Okay. Thank you all to this committee, and as we move forward. Okay, Rice.
Rice always says something to say, but, I think this is good work we've done, but under that funding, I want to ask you to think about, are we tinkering with a model that worked great after World War II when we bombed out our economic competition and had money to spend like nobody's business? And we started out doing what people wanted, but I think in the last 40 years we've been doing what people like us want, and boards want, and Robert Wood Johnson wants, and universities want, and not so much what the guy in the street wants and the guy in the business wants. And I'll just tell you that in Lexington, I have found, since I can get out in the community a lot more lately, that there are people in business and other organizations that don't know what the heck we do, but when they find out what we do, we've got allies to go talk to the General Assembly on our behalf. We have allies to go talk to others. And I will tell you, one group of allies that I think y'all are afraid to talk to are physicians. I was at an AMA meeting, had my Swiss Army knife confiscated, trying to get into the United States Capitol. Them boys don't screw around up there. They didn't want just my knife. They wanted my driver's license, my social security. I can't wait to see my FBI record. But I was with a physician from one of our counties, and the guy said, well, we were just talking in general, and I forget why we were sitting in a Starbucks. And I was telling him about everything we do, and he says, man, I would love to know about that in my practice and at our hospital. And I noticed when I was commissioner in Frankfurt, y'all act like you're afraid of doctors for the most part. They're just jerks like me, you can talk to them. They drink coffee. We need to reach, I'm making a point here, underfunding, we need to find out who we're helping besides that population of disadvantaged Kentuckians that don't have the political power to tear a piece of toilet paper in half. Let's reach out to the power structure that elects guys and influences money, along with everything else we're doing underfunding. End of sermon, I hope.
The super utilizers meeting right now is going on. I've heard directors say, what business have we got, what concern is it of ours in public health about whether or not someone goes to the ER? As we look at the overall use of healthcare resources and we talk about our partnership there, it's great that public health was considered to do this, because we've got them doctors, those hospital administrators now in some places who never really thought about their health departments, who are really wanting to reach out and partner now. So we can look at it as a great opportunity. With these super utilizers, how we can work together as we talk about community health workers, helping to manage individuals to remain in the community. There was an editorial letter to the editor from the chairman of the board, I believe it was Kentucky One Health, talking about how, you think the past few years have been tough on us. It's throughout many different sectors of the healthcare and public health industry. Kentucky One Health is talking about totally restructuring and moving from that focus of fee-for-service, being reimbursed for keeping people in the hospital, to focusing on how do we keep people well in the community. Something very, very different from them being hospital-based. And so just fundamental transitions in the way they're doing business. So, it's all about now how can we partner. And I think, with KHDA, as we look at this strategic plan for public health, this strategic plan, we need to engage our partners. Just like we do in our local communities, we're conveners. KHDA, we need to be conveners here and bring people to the table that are our stakeholders and our partners. Okay. Any other comments about this?
Can you give an update on the super utilization?
Okay, and that's what DPH, when they get here, they may want to touch on that more. But I know, the super utilizers work group there, targeting 16 communities, looking at those individuals who are utilizing, and I believe there was, from the data Dr. Langfield presented, there were 2 people in the state who had been to the emergency room more than 120 times last year.
One was 180.
Yeah, one was 180. So think about that. They went to their emergency room 180 times, and I think one of those people had went to like 30 different emergency rooms. So, so that MCO needs to just call that individual every day and ask, are you going to the emergency room today? Is there anything I can do to support you? So when they're looking at that, that conference was very nice last Thursday there. It was the direct public health directors, hospital administrators, key partners there from those 16 communities that are targeted right now. And these 16 communities were chosen because they had some of the highest super utilizers in the state and their involvement with the KHDA and looking at that. So again, this group, I know that there was the potential, and DPH can update us on this about funding, was they applied for a grant hoping that we would be able to expand this more across the state to engage more hospitals and health departments and partnerships in this.
Is there a model coming out for it?
Yeah, I will let them talk about that, Allison, and just, because being, there in attendance, that was, I think that they were really looking at, how I think that the main focus right now is convening, getting everyone working together and looking at the issues. I know I think it was the hospital administrator from St. E's, or their medical director, that he presented some really great data on looking at how people get to their emergency rooms. They were looking like 80%, came by car, and what time of day they present to the ERs, and are there urgent treatment center options available during that time, and different things of that nature. So, there's some great data, and I know Rice made comments there. We got so much data out there. How do we take this data and really do something with it now? And so we'll ask that question when they get here, and let Dr. Mayfield and Dr. White and Dr. Humbaugh address that super utilizers group. Okay. Anything else then right now? We've got a few minutes here open. Any other questions?
Hey, Scott, this is Kent.
Hey, Kent.
When you were talking about the Foundation for a Healthy Kentucky, were you talking about the KHDA applying for that grant, or was it okay? So I guess we need to work together on that, and as a group on that particular grant, as opposed to other individual groups throughout the state working and submitting that application. Is that correct?
Yeah, KHDA is looking to, as a group, we've been communicating with University of Kentucky, the Public Health Institute there at the UK, Cynthia Lambert and her team there, to see how we can strategize, pulling in the State Chamber of Commerce. We've had contact with them, looking at, as far as policy development, focusing on these regional policy development forums, institutes, whatever you want to call them. Kind of been one of the strategies that we've discussed right now, how we could educate our policymakers about health and all policies, potentially even tagging on like like Dr. Sadler was talking there earlier about a policy maker boot camp, or policy boot camp for public health directors and people that want to pass public health policy. What is the process? How do we need to go about it? How does our legislature work? Behind the scenes actually truly work, not just the way that it supposedly works. And so really focusing on those things to make sure that we're all astute and educated, and our policymakers know about health and all policies. So we're still trying. We've been talking, Susan Zapata at the foundation, to talk about how we can leverage the most funds, who needs to be the lead agency to apply because of the budget restrictions. If you have a budget of less than, I think it was $200,000, you only qualify for $25,000. If your budget's greater, you can apply for $50,000. So, we're thinking right now that there may be actually a couple of applications. One may come from UK, one may come from KHDA, or maybe through the chamber. We don't know yet, to actually try to leverage the most funds to support these type of endeavors. And I've also heard that there are several other groups across the state that are going to be applying for these funds as well, outside of health departments. I don't know, there may be some other individual health departments that want to be applying, as well. I don't know, what all's going on out there, but just to let everybody know, KHDA is going to be doing an application on behalf of, trying to partner for all of us, for everyone's benefit here.
Thank you for that explanation.
Thank you, Ken. Okay, anybody else? Any other comments from ITV or in the room? Okay, we're actually ahead of schedule here by a minute. We're going to take a break. Thank you. Our places, please. ITV, we're getting ready to get started back here. Okay, everybody, let's grab a seat, please. Yeah.
Good morning, everybody.
As we always talk about partnerships, one of our key partners here at the Department of Public Health, Commissioner Mayfield, always a pleasure to have you.
Thank you. Good morning, everybody. Thanks for having us. A couple of things on our agenda besides our updates from our division directors. I want to thank all of you all who were participating and continue to participate in the super utilization project to enhance quality and improvement in the emergency department, improve outcomes, and ultimately lower costs. We had a statewide meeting, and the governor and the secretary were present to offer their support. We feel like the stars are aligning for us right now. The Connect, which many of you have been participating in and getting people signed up for insurance, we're greatly appreciative of that. We have tipped over 306,000 people that have signed up for insurance at this time, so we're absolutely delighted with that news. The stars continue to align with the Kentucky Health Initiatives, and I was really glad to see that your strategic planning you had done incorporated the initiatives that the governor was including as well. That with our Kentucky Health Information Exchange and our managed care organizations, we have a meeting with them later today. We're really trying to get the state healthy. Now, as far as managed care organizations are concerned, today we have a meeting and to meet with some specifics on some things that we want to ensure you get proper reimbursement for. Dr. White is going to be talking about the ACA driver's manual today and some opportunities. In May, I'll be meeting with the Humana Vice President. I believe we're visiting Deborah Philman's shop along with Scott Lockhart, and we're going to ITV into you during a CADA meeting. Many of you have, or some of you have been participating in the Humana Vitality. And I hear that's been rewarding for patients and financially very good for you as well. Well, there may be some other similar opportunities for you that we're going to explore. So more to come on that. I have invited the Commissioner for Medicaid, Commissioner Larry Kistner, to come and talk to you about your questions with family planning, CHIP, and breast and cervical cancer. So I think you'll like that news. After that, we'll have the updates from our Deputy Commissioner of Clinical Affairs, Dr. White, and then we have Mike Tuggle, who's going to give a couple of financial examples of looking at if you were to take Medicaid patients, the new Medicaid patients that there's no match on, for preventive services or expanded services, what will some of your finances look like? So we took real counties and we took information from real directors who were doing different models that we thought you should have a look at to help you further develop and do a really good, strong actuarial analysis. So without any further delay, Commissioner Kistner.
Okay. So, what do you want me just to talk about the?
What we decided on.
Oh, okay. So so there's a match rate that's different on I'm purposely not gonna. You won't be able to keep me on that screen. Because I'm gonna walk. I had too much coffee. There's a match rate that's different for CHIP and cervical cancer and family planning stuff. So we're gonna adjust that coming up in the new fiscal year. We're gonna lower your match rates to comply with that. So I think it's like 10% and 20% on the CHIP kids are 20% and the family planning is 10%. And the ACA is, the other one's 20. Yeah. And then ACA is 100%, so there's zero match on any of your the new ACA members. And that's the bulk of the people who are signing up for under the expansion. We did have some woodwork effect. Woodwork are the people that were eligible for Medicaid today, but weren't in Medicaid. And we thought we identified about 60,000 people in the state that were eligible and weren't in the program. That's actually the entire impact from a state budget perspective is woodwork people, because their match is the old match 70-30, not the new match of 100-0. So every time we find a woodwork member, it's financially important to the state, and that's and it looks like we've hit our target of woodwork. We anticipated 17,000 woodwork people we'd find them because of Connect and the ease and the new Magi determination. So eligibility for Medicaid is simple. How much do you make? Is it 138% of the FPL, $15,900 rounded? Do you make below that? Yes, you're eligible. Okay, we took the old, which was the old formulas were complex, and they had spend down. There's lots of different things that was associated with that. And for the most part, we kept some of the spend down stuff for the waiver programs, but some of the other stuff, for the bulk of it, we just converted. So a single male without kids was 0%. You couldn't get Medicaid coverage. Medicaid was designed way back when for women and children. So any single male who makes below $15,900 is eligible, and that's an ACA expansion member. For somebody who had a kid, women with a kid or a male with a kid, it was ballpark 30% of the FPL. So say, $3 or $4 grand. You made less than that, you were eligible. So when we did a conversion to that 30% number of FPL took into consideration a lot of different things. So we had an actuarial firm, and then the government had an actuarial firm come up with the conversion factor, and it worked out to be about 40%. Okay, so anybody who makes less than 40% of the FPL is old Medicaid, 40% or more is new Medicaid, and that's sort of that woodwork is the old, expansion is the new is 100-0, the old is 70-30. So it's pretty important financially to the state as in terms of the budget of what's going on there. I know you guys are thinking, what does my business plan look like? What does my modeling look like? How am I going to make money? How am I going to survive? What's going to happen? What's the new world of healthcare look like? And you know what? I don't know. It's going to change a lot. And I don't think, I had everybody who comes into my office, everybody comes in, they sit down, we make some small talk, and then comes the money. Because it's never about the money till it's about the money. And it's always about the money. And they say, I don't get enough money. Medicaid doesn't pay me enough. Well, guess what? Medicaid sucks. We pay 77% of Medicare across the country. That's what Medicaid pays for. It's a state-funded 77% of Medicare, right? And you talk to physicians, nobody says Medicare is enough, right? They need more than Medicare payment. So across the board, Medicaid is the worst payer. We're the payer of last resort. It's the worst. So I'll give you an example. The Ambulance Association, there's two of them, and they came in to see me with their lobbyist and said, we don't get paid enough. We have the lowest unit costs in all the ambulances and all this stuff. And then they proceeded to tell me that, it looks like there's a lot more helicopter use because helicopters pay $2,500 a trip and an ambulance pays, $60 a trip. And we don't get paid if we don't take them somewhere. So you know what? We take them places. We take them, and they're not necessarily an emergency because your non-emergency medical transportation benefit doesn't pay for trips to the pharmacy. And they give me all this information. So I pull the data, and I said, well, and this is why some people don't like me, because I refuse to accept verbal statements as fact. So I pulled it. Well, number one, helicopter transportation has actually declined over the last 3 years. Okay, so that was one, saying I think your information's wrong. Your anecdotal information's wrong. The data's pointing in another direction. But I agree with you that non-emergency medical transportation does not cover trips to the pharmacy. So what happens is somebody calls up and says, I think I'm having a heart attack. I'm having chest pains. They show up. They have to, by law, show up, right? They're there, they do some analysis, they do some triage, and the guy says, well, it's kind of hurting more yesterday, but I really need to get my prescription refilled. Now, if they don't take them somewhere, they don't get paid. So what do? They take them to the emergency room. And when you arrive in an emergency room, now anybody, this should not shock anybody in this room who's familiar with the way that ambulances work. They don't get paid unless they take you someplace. When they take you to the hospital, that's one of the rules of, is it a true emergency? Well, if you arrive by ambulance, it's kind of de facto an emergency. So your mode of getting there is important. So they could just as easily take them to an urgent care center in their county. And the average urgent care center is $100. The average hospital emergency room is like $800. Okay? So I said, so take the difference. So go to the MCOs, and I wrote this all in a letter to them, and said, here's all the facts, here's all the data, here's all the information about what's happening currently over the last 3 years with emergency medical transportation. If you go to the MCOs and say, tell you what, set aside an extra 20% of the reimbursement. Don't pay it to me today, but set it aside. And if I can reduce just 10% the amount of emergency hospitals by taking them to an urgent care center, we'll split 50-50. It was millions of dollars, tens of millions of dollars. And if they got to 20%, we would actually be the highest reimbursed per unit medical transportation around all the 7 states that they did their survey on. There's ways which actually is the right thing to do. Pay more per unit. I get more. I get a higher reimbursement, and I save you $500, $600, $700 by not taking them to emergency room. That same thing is where you guys should be thinking. What creative thing? I don't know. Go to the MCOs and say, hey, do you have any gaps in care? I know they do. Didn't have a mammogram. Didn't get a hemoglobin A1C test. Didn't get a child well visit. And let me help you with that. Pay me. I'll go find them. I'll get that service delivered. I'll make sure they get something done. But I need to get reimbursed. So what does wellness save you? I don't know. But there's some math involved that says no wellness visits could equal a bad situation down the road. And we're at the point in time where there's not a lot of turnover anymore with the membership. Once Kentucky Spirit left and we reassigned 125,000 people, and once ARH canceled their deal with Coventry way back when, those were significant points in time because there were significant shifts in membership. But the last open enrollment period, not much. 5%, 8% of the people shift around. So they're managing a stable population, and that's important to understand because now I can bake in. That's what we want. We want them to have a population that stays stable, and they can manage their disease management, case management. They can get the hemophiliacs under control. They can get the sickle cell patients under control. Get them to be monitored. Get them to be tested. Get them on their drug regimen because that saves money in the long term, and they get to see the value of all that expenditure on their end to manage care. So we're at that stable place in time. All the open enrollment period that's going on in another week or two, we're going to have an open enrollment period effective 7/1, but they'll change. I think it's between April something and May something. There's a 30-day open enrollment period for all the people who were to be effective on 7/1 to basically all in the seven regions outside of Region 3, if they want to change. But it's one of those, like a negative enrollment thing, where you have to take action. Otherwise, you stay where you are. If you're happy, you don't have to do anything. But if you want to change, then you got to actually be proactive and make a change. So we don't anticipate a lot of change there, but they have the opportunity to choose Anthem or Humana or Passport out of the 3 now statewide, with the exception of Region 3. Anthem's not in Region 3. There's 4 managed care companies in Region 3. The rest of the state has 5. So we're letting them choose if they want to. So, but I don't anticipate a lot of switches, because once you're into a managed care company and once you've been there a couple years and you sort of fight the battles of step therapy, you fight the battles of prior authorizations for all the services that you get rendered, and then once you get on a regiment that works with you and works with your doc, and you're sort of in compliance with your drug regime and you're on generics to the degree that you can be, then you're kind of okay. There's no reason to change, unless your doctor leaves or your hospital cancels their contract. So, but that's sort of my random thoughts. I'll take questions, I guess that's okay.
Yeah, no, that's fine. I think we've got one over here.
Sure.
Yeah, Commissioner Kistner, first of all, I'd like to say thank you for taking your time and coming and addressing us today. I'm glad you talked about, reaching out to the MCOs. We talked about it a little bit earlier, but, because the governor is showing savings within ACA and has the expectations that we'll be able to make up some of the revenue in regards to that, I'm wondering if, because we contract with DPH and DPH contracts with the MCOs, I guess my question is can DPH and Medicaid work together in providing us roles of individuals who's not received their preventative care, in over a year, so we can actually reach out to those participants?
Well, that's exactly what Commissioner Kistner was saying, that you can contact. You all have the flexibility to also contact the managed care organizations, and I can take this to the managed care medical directors meeting today to ask specifically for that, but there's nothing prohibiting you, and correct me if I'm wrong, Commissioner Kistner, from contacting them and saying, what do you need? And you can help them with what they may need that they may not be thinking of. I mean, we're all in this together here. So nothing prohibits you from doing that.
Well, I'm just looking at a more efficient model.
And I will take that to the meeting today.
I would hope that would be something that would be available
Right.
to all local health departments across the state that
Right.
we can work toward.
Right, and I will take that to the
I
meeting.
only have one area of concern, and that's what we do with EPSDT, and I mentioned this to you earlier, but not to the group. Right now, we provide you guys with a list of all the kids and their annual screenings are available. Some health departments are very aggressive in getting the parent to bring the kid in to do the annual visit. And the pediatrician never knows that took place. There's no sharing of data. We provide you guys with a list. You guys work the list, generate revenue, but there's no, which I'm not opposed to. I mean, getting it done is getting it done. That's the good part. But we never close the loop to the primary care physician who sees the kid for the other 5 times a year when they fall down and scrape their knee or, break a bone or get, something serious, a flu or cold or something or pneumonia. They go to their pediatrician. So what happens is the parent comes in, pediatrician bills, and it gets rejected because we only pay for that one time a year. Once per year per kid. So, that's sort of that well child visit. So that I'm not happy with that because it's a disconnect. It's not a well-rounded healthcare cycle where sharing of data, that's where the government's going, that's where the world's going is, that's Google Health. I mean, you want to be able to have other people access that information and know that that was delivered so that I can provide other services. So, but think about that. Think about how you get the information. Who is your primary care physician? Who's your pediatrician? Because everybody, all of the managed care companies have a primary care model. So on their card is the name of their primary care doc, right? So they all have one, and that's where that should be home base for medical records.
Another question I have.
We're not at all happy either with the
money. No doubt about that. So the question that I would have regarding the pending match, our estimate is from fiscal year 2011 through fiscal year 2013 that we overpaid about $1.1 million.
Yep.
What's our expectation for having that?
0. We don't have the money. And you really don't want to go down that path. If you go down that path, because there's nothing that says we have to pay 100% of Medicare. So we could drop you to a Medicaid reimbursement rate and then pay away by saving money on one end to pay on the other. And it would invoke an audit. It does a complete audit of all your books and records, which could take years. So my recommendation is don't go down that path.
Okay, on ITV, check, please. Everyone check your mic. We're getting feedback on ITV. So everyone check your mic to make sure you're muted, please.
Can I just interrupt here? I'm sorry, I got a meeting with my boss. I'm gonna have to leave in a second.
I should leave when you leave.
Okay, you actually may need you too. The superutilization, many of you are very familiar with it, but if I may have an invitation to come and talk about how this will impact local health departments. Many of you know already, but these are wraparound services that we're building. These are things that, we're at the forefront being who we are in this activity. So if you would like, I would love to give, I'm very quick, 10 minutes and a review of where we are, what we're doing there, if that's okay with you all.
Absolutely.
Okay. All right. I was hoping we were delivering some good news to you today, and to let you know we do hear you. And when I say we're in this together, I'm not just saying this. We are constantly trying to, obviously we want to improve the health, but we're trying to give you some sustainable funds too. Things are different. I think we've all accepted that and come to the conclusion. And Dr. White is going to be talking about many different types of activities that may or may not be right for you. Mike Tuggle has some business plans for you where some health departments are hiring more APRNs and physicians because they feel like that's what their population needs and they feel like it's going to be profitable. So we've got some interesting things for you today. And again, as the secretary said many months ago, these are menus for you. This is, you don't have to accept, but we're working hard to give you some sustainability through all of this change. So with that, thank you for, okay.
Thank you very much, Commissioner Mayfield.
Thank you.
So the managed care company gaps in care, that's significant. If they want to close their gaps in care, so reaching out to them and saying, let's develop a plan where I'll help you close your gaps in care. We have feet on the street in every county. We know where the members are. I think that's an important tool that you have in your toolbox. You know the people. You're there local. You can find them, right? But all that, you'd have to look at your own resources and say, how do I find somebody? Do I have somebody that can get in a car and go find somebody in a holler somewhere and say, and do a home visit and say, hey, how come you stopped taking your medication? How come you didn't refill your hemoglobin A1C, drugs, or diabetes drugs? And are you still monitoring your blood sugar? The MCO wants that to happen. An unmanaged diabetic is about $13,000 a year. A managed diabetic costs $3,000. So they can save $10,000 by getting somebody to be a managed diabetic. Our hemoglobin A1C, feet checked, eyes checked. Our statistics, I've looked through them. They're horrible. We have counties where it's 10% of the known diabetics have had their eyes checked. There's nobody who's celebrating that result. It's a horrible result. So the MCOs have driven some huge improvements. Chlamydia screenings went from 6% to 50%, actually 48%. But nobody's high-fiving that, well, half the time we're checking for chlamydia. That's not what success looks like. Success looks like the trend line from 6% to 50%, but it's that result isn't like nobody's high-fiving each other about, yeah, we got to 50%. The best health plans in the world, Harvard Pilgrim and other health plans, they're driving, they still don't get 100% of women with a mammogram that should have had a mammogram. Nobody gets to 100%, but they get in the high 80s, and that is the best. 88, 89% of the people get a mammogram when they should have a mammogram. That's success. That's what it looks like. And so when you look at Our C-section rates, we're at like 35%. That's horrible. There's other countries that, there's third world countries that don't have that level of C-section rates. And we're, as an industrialized nation with that, that's not a good result. And we should be driving, more vaginal deliveries. It's a healthy event. It doesn't have to be major surgery. And there's a lot of reasons why. We pay more for C-sections. It's more convenient for the providers. We don't allow a lot of midwives in the state. We don't have a single alternative birthing center licensed in the state of Kentucky. I tried to get a spa approved, and the feds said, hey, you don't have one. That means you got to pay for stuff out of state. If we approve your spa for alternative birthing centers, you have to then pay for Indiana and Illinois and Ohio and Tennessee because they have them and you don't. And I said, well, I don't know if I necessarily want to start driving moms out of the state to have an alternative birth. But that's all, there's lots and lots of reasons and where you can change that number. And I've done it in several markets. And it boils down to midwives is one of the secrets of the sauce. Get more midwives operating, get them with more home deliveries. And, there's lots and lots of very important lobbying organizations, powerful medical organizations that don't necessarily want that as an outcome, but because they want to protect what's coming through them. But those are the things that should change. We should look at our results and say, what's happening? What's the results? And if we can drive, and that's where I would start with the managed care companies. What do you guys want us to do? What does success look like for you guys? Ask those very open-ended questions. What do you want us to do? We have people, do you have any patients, do you have any members in this county that have gaps in care, that are avoiding necessary service, that haven't had something done that you think should be done that's really important? And I guarantee you they will say yes, and then they'll say, okay, pay me to do it, and I'll do it for you. I'll be your eyes and ears and feet on the street, and I'll do it. Does anybody need a home assessment? Right? So try to manage an asthma patient. Ventolin HFA is our #1 drug across the board, #1 drug prescribed in Medicaid. Across all the MCOs, everything, #1 drug. It's an asthma drug. It's a generic asthma drug, costs $43 a month. Well, do you smoke at home? Does somebody else smoke at home? Do you have a cat? How clean's your house? Do you have mold? Well, those are all things that you'll never manage the asthma unless you manage all that other stuff, right? Well, how does the MCO know that? They'll either pay for somebody to go do it, which I've done in the past as a CEO of a managed care company, or I pay somebody with a contract to go do it. I have this asthma patient. They keep getting readmitted to the emergency room because they can't breathe. Well, they need training. They need to understand how to use the inhaler. You got to teach them, and they need face-to-face, walk them through it, show them how to load the cartridge, how to do it, what's the little thing where you blow the bubbles and check your lungs and all that stuff. I need training. I need on the ground, in the trailer training. Somewhere, somebody's not doing what's right. How can I help you there? Because I paid for that. I paid for nurses that were in the county. I just hire a nurse. I need you to go do this visit. It's going to save me money. One hospital, one emergency room is $700 because I can't breathe. Oh, if I can avoid that, I just save $700. So I'll pay somebody $100 to go to their home and do a $50, $80 for a home visit. That's totally a very effective ROI, right? Well, that's the kind of thing you gotta start engaging the MCOs and saying, what do you guys want? What does success look like? What can I help you with? Yes.
When we go to engage these MCOs, are we allowed as individual health departments, because the Department for Public Health is our Medicaid contract?
Mm-hmm.
Can we as individual health departments negotiate or bill MCOs separate, so we'll actually be two partners? We'll be doing services on behalf of the Department for Public Health, and we'll be doing
the mechanics. I know the mechanics. I don't know the answer.
Okay.
But
I'm glad you don't.
I don't know. But the concept, I can tell you 100%. We have a contract with DPH, right? DPH has, I think, a contract with you guys. And there can be an amendment to a contract. And it could be a single local health department amendment. That's not a problem. We create amendments all the time. So I think there's a way to make it legal and make it happen. Then it becomes how do you bill it and do it? I would love to see 5 or 10 unique amendments that pop up that say, hey, we're doing this. We're going out, we're doing home visits, we're doing something, and they're paying us a little bit more, and we're doing it. And then next year you guys come back and say, hey, we did this with Coventry, we did it with one MCO, and we cut a deal, and here's what the deal was, and here's the results. We made 400 home visits, and it was a positive ROI for the local health department, and we kept the guys, we avoided a lot of hospital admissions and ER use. It was a success. Here's what it looks like, and feel free to do that. You know, I don't think there's downside to experiment. You can come back. I mean, that's one of the things that for the people who don't like Kentucky Spirit, that was actually one of their big things was experiments. And they did a lot. Centene Corporation, the parent company, that's one of the things they do. And they had developed a number of different pilots, and some of them succeed and some of them don't. You know, they were looking at the ER use, and anybody who's been involved in the super utilizers group know that there's I'm going to ballpark here, 400,000 in a year, 400,000 emergency room admissions. Half of those admissions are multiple, 2 or more people, 2 or more visits per person. Half of them, 200,000, one visit, one time during the year. Okay? So I asked the question, I said, so I understand you're looking at super utilizers because they're a unique group of people, but don't overlook the one-time use, because who are the one-time use? And Centene had already done this analysis. Anybody want to guess who what the person looks like who's using it just one time a year? What's their overriding characteristic? They're a kid. They face plant somewhere, or they're skateboarding somewhere, or something happens and it's traumatic and you go to the emergency room. They're a kid. So how do you keep, because if you could have a 10% improvement in that, you save 20,000 visits. You have a 10% improvement over here on the other side, you save 20,000 visits. They both have the same financial impact. So don't overlook the one-time use. Well, they went through all their pediatricians and said, you know, here's all our pediatricians, and if we boil it down, we have our top 15 pediatricians whose members are using the ER one time or twice, but they're kids using the ER. So maybe I could cut a deal with the pediatricians to say, hey, I'll pay you more if you can stay open a little longer, because I need you to be open at, you know, if you can stay open at 6 o'clock or 7 o'clock, you know, a couple times a week, maybe they wouldn't rush to the ER. They'd do a nighttime appointment or something like that. Because you only need to save 10% savings, and every doctor visit is $55 or $50, and every emergency room is, you know, several hundred. So there's an ROI, immediate ROI. Well, that's the kind of stuff that they're thinking of and they were doing. And I'm totally supportive of experiments. Get one maniac local health department that wants to change the world and create something and see if it works. And if it fails, it's a glorious failure. Try something else. But if you just keep doing the same thing, for the last 20 years, the service delivery in local health departments has changed. You've stopped doing medicine. You do a lot of stuff you do a lot of other stuff. There's CDC stuff, and there's public education, but the actual delivery of health care, you know, with a stethoscope, nurses, doctors, has been declining. There was a bump back up when we started doing in-school work, and that helped back up. But when you look at the big picture, you guys have changed your models, and now we're saying, so what if we keep doing? If I don't make any changes, what's going to change? If I don't make any creative thing, it's going to be the same old, right? So
one thing in response to what you said and your question, Allison, we've got a work group that started in January, and we're just about ready to present to MCOs a pilot project for healthy home evaluations for asthma. We're working, we've talked to people that have done this in Connecticut, we just talked to people who have done it in St. Louis, we talked to people who have done it in New York State actually has a payment for a home visit, because there's not, in Kentucky, we don't have payment for that. So we've just about got that ready so that we can present it to the MCOs on behalf of the health departments and say, you know, we're trying to find places where there's we're trying to find lots of asthma patients in one place that's got maybe an asthma health educator and a healthy homes evaluator, so we can show a real quick return, because we know that's important. So that's one thing that we're working on that we're really close to being able to present. The other thing we're working on, and we're very close to that, is the community health worker, which is exactly what he's talking about, to have somebody go out to the home and say, show me your book, you know, let me look in your refrigerator, you know, Mary Lou, you can't drink 6 liters of Mountain Dew and be a diabetic. Let's talk about that. Those kinds of things. We've got one pilot program in Taylor County where they're using nurses, but they're going to, when that contract's over, they're going to use community health workers. People have had strokes, and they're not doing home health, so it's not stepping on something that's already being done and paid for. This is to make your follow-up appointment. Have you gone to see OT? Let's get those throw rugs out of the way that you're going to trip over and break your hip now that you've had the stroke and you're dragging your leg. You know, those kinds of home visits, exactly what you're talking about, and we're getting a model put together so we can go to the MCOs and say, other states are paying for community health workers to do these things. We want to do that with the MCOs in Kentucky. So those are 2 projects that will be something that I think will be very useful. We're very close.
Right. Here's 2 more. Anybody who's being discharged from a hospital, are they in a wheelchair for some period of time? Because do they have steps? Can you get through the yard? How do you get in? How do you get into the house if you've got steps and you're in a wheelchair? Somebody picks you up and, you know, moves you, but it's tough. And if you don't have a good support group, you know, cousins, nephews, somebody who can physically lift me up, right? That's one where you could go in and say, hey, this person's in a wheelchair. Any amputation, anything like that, where you're saying, God, there's wound care, they're not going to be out of the wheelchair for maybe forever. But that's one. And 2 is long hospital stays. So if somebody's alone and they're in the hospital for a week, right, and then they come home, what's in the fridge? Almost nothing that you can eat, because there's the 5-day rule, right? If it's leftovers, you can 5 days, except on Thanksgiving, then you get a 6th. But you can't. But it's 5 days. That's the rule. At least that's my wife's rule, and I kind of think it makes sense. So there's probably nothing in the fridge that's edible. So then they're home with no food, and then what happens? No food, or they call 911 and get back to the hospital, get something to eat. The result is all bad, right? Something needs to happen. So I've actually paid, as a CEO of a managed care company, I paid for somebody to go get, you know, bread, milk, some ham, you know, get some food in the fridge, get some cans of tuna, get some stuff in there, because I don't want them to have to leave again. I can spend $50, $55, $60 in food, and that's a good ROI for me to avoid one more hospital admission or a readmission. And the readmissions tend to happen within a 7-day period. So you got a sweet spot, leaving the steps of the hospital within 7 days of that event, and that's when they tend to have a readmission. And if you can get past that first week, you know, with counseling, with training, with here's how to wound care, here's, you know, making sure the home health care nurse is coming. There should be one coming, right? Especially if you've had an amputation or you've had something serious, there should be somebody coming to your house to visit. How are things going? I'm showing you how to do that wound care. Yeah. So making sure, facilitating that, making sure that happens.
Something else we've talked about, and nothing's ever moved on it, are, from what I understand, the MCOs are saying they can't find people.
That's right.
Just flat can't find them. So how's the best way for a health department? Is it better for them to go as a group? Is it better just to say, I know where the people in my community are, and you can't find people? How do you contract that with me? I mean, what the mechanics, so that we'll know what's in
I think public health takes a leadership role, cuts a deal, and says, you know, this is like hiring a private investigator. My brother used to work for a company that was did that kind of stuff, not private investigation, but did like the credit checks and stuff. And they used to put proposals out to governments and say, I'll give you the current address of a deadbeat dad for $25. I'll search all the known databases and give you the last known address, $25. I'll actually make sure they're at that address for $50, and I'll present them with a warrant for $100. And I'll help you, because deadbeat dads are bad, and they should be taking care of their kids, and so I can help you with that, because that's an obligation the states have to pay if dads don't pay their fair share. So it's kind of the same thing. It's like I can find somebody for a small amount. I can actually go visit them and have a discussion with them. Like, because some people, we have found Medicaid, it's a pretty mobile group, which kind of surprises people. But every time we do a mailing, 30% of it comes back with it's a mobile group. And so do you spend time, well, I go to my sister's house, I spend a week with my sister, I spend a week with my brother, I'm actually at multiple locations. Well, having that information is important to the managed care company. What's your brother's number? What's your sister's number? And because they can then find them. Where are you this week? It's Belgium. It must be Tuesday. I don't know. That's the kind of stuff where I think they have in their contract with us, they have to they have to find people. They have to outreach to them. They have to do a health risk assessment. You guys could do the health risk assessment.
Would it be like an adult EPSDT outreach?
Kind of. I mean, yeah. It's the MCOs can pay for both stuff that's under state and outside of state. They can pay. They can do whatever they want to do with their capitated premium. So if they're believing that there's a value to paying you to do something, it may or may not even have to be covered under Medicaid. They can still pay you to do it. It's because that's the kind of stuff that happens quite a bit. Build a wheelchair ramp. Pay for a prosthetic eye. Yes.
You are describing the role of a public health nurse in the days before Medicaid and fee-for-service, when they were paid what amounted to block funding by either county government or state government. And they weren't all registered nurses. Some were LPNs and some were workers. That's the kind of work they did. But then we got into the gravy train of Medicaid, and everybody came back into clinic and did fee-for-service work, which has run the cost up and may or may not have made any difference in aggregate health care. But the trick is to find a way to get the fee-for-service funding world to fund that kind of block grant stuff. And one of the points I made before you all got here, those public health nurses visited the doctor's offices and talked to the docs about these patients, or the doc's helper. You get that put back together, then you got a real honest-to-God future for public health departments. But you know my thoughts on getting back into direct care fee-for-service. Good luck, because you're going to be competing with the guys that can do it for less.
Yeah. Yeah, they may not know your county like you know your county, but if they can do it. There's a competition. I like competition. Competition's good. Spurs creativity, and we wouldn't have a smartphone if there wasn't competition.
Any other questions for Commissioner Kistner?
Hi on the phone. Big smile. Is there a time delay?
Okay.
Well,
all right.
Thank you very much, Commissioner Kistner, for being with us today.
Which I wasn't gonna do this now, but I'll use this as a segue. What Dr. Mayfield was talking about, and we presented this to the KHDA Executive Committee. I don't know if y'all talked about the KHDA Executive Committee coming on the first Fridays of the month to Dr. Mayfield's executive staff meeting. But we presented this to them last week, and I haven't heard anything back. There hadn't been a lot of time. I'm sure they may have some changes. But I'm going to be emailing y'all what Dr. Mayfield has been calling the driver's manual. And what the driver's manual is a menu of suggestions and ideas and things that have worked in other health departments. None of these may apply to your community. You may look through this and say, nice try, not close. You may look through this and say, none of these things would be helpful for me, but we are doing this little thing that's been kind of nice for our community and has been something that's a sustainable model for us. We want this to be, I'll send it to you electronically, but it's going to be an online document that will be always changing. So if the health department's doing something that's really working, let us know. We'll put it in there and then put your contact information. So if White County Health Department says, well, I like, what Ron County Health Department's doing, I'm going to call them and see how they set this up. So it's a combination of things from community health workers, and we've got in there, it's not paid for yet, but the whole concept, let you know we're working on getting that paid for. Things like doing worksite wellness in community, in companies in your community, and there's some resources for that. Like they're doing at Lincoln Trail, where they're actually embedding some of their health department staff into a large clinic. That would work for some of you, won't work for others. So I'm going to be emailing this out. Please let me know if you read through it and you think it's got some good ideas in it, use them. If it doesn't have any good ideas in it for you, don't use them. If you've got some ideas that aren't in there, let us know so we can share that. It's kind of like a best practices, but I don't like to use that word. I think maybe it would be more like usable practices, things that might work in your community that you might not have thought of. So that's one thing, and I was serious about talking about the two lines of payment we're trying to establish, and one would be for home health visits. And what the other communities have done is they've had different level of home health visits. And because the managed care company have asthma case managers, and if people will actually talk to them, I mean, I kept telling the HMOs, or the MCOs, and when somebody calls and says, I'm calling about your asthma, and Mary Lou says, well, who are you and where are you from? And when they say Milwaukee, they're going to hang up on them. It would be like a lot of people that I know in my community. But if we can actually find out who's got the most ER visits, that would involve a visit from somebody with a Healthy Homes. It would involve some contact with an asthma educator, and then some follow-ups with your community health workers. So you're not sending your nurses for lots of home visits, but the nurses would be supervising what the community health worker would be doing. So lots of ideas. I won't go into all of them. This is not a thick document. This is not a how-to. This is here's a link for where to get to find that information. And here's a link to somebody that said they'd be glad to talk to you about it. So that's some of the things that we're trying to do. So please help us with ideas that you have so we can expand that. So I'm going to send it out electronically to y'all, and then we'll get it online on the website, on the local health department website, so y'all can look at that for what that's worth. Let's go ahead and start doing, because of our time, some of the reports. And let's start with, I think, Mike, this might be a good time for you to do your presentation. Does anybody have any questions about that while he's coming up?
Ron and David's having me hand out some papers that follow on the screen here as well. So for those on ITV, I do apologize. I don't know what you can see on the screen. It may be difficult. I'm standing here as well, so maybe if I move to the other side, that would be of value.
Will you be able to send those out email to us?
I will. Actually, I can ask Ron to actually alert the public health and see if we can get that sent out while I'm talking. How's that, Kent?
That'd be great.
That's nice. Hey,
So
Dr. White, White's finished saying, since we know that this meeting is monthly ITV, could DPH staff go ahead and send out any handouts beforehand, since we know that there's going to be folks viewing in remotely? I mean, that just seems sort of common sense to me.
Absolutely. And this particular piece of paper was just put together like before we came out here, but you're absolutely right. Anytime we've got something, we do need to do that, Dennis. You're correct.
But it'll be sent to everybody's email. So Ron, you'll help me get that communication over to public health, okay? Kind of dovetailing with what Commissioner Kirsten was saying, there's opportunities out there with with ACA for everyone, including health departments. And what I did is take some of the information that was what's going on currently in counties across the state. So what we're going to look at here, actually, I've got 3 different scenarios, counties A, B, and C. And it shows what's going on today based on what was thought to happen and what's really going on. So let me go through some of these scenarios, show you where there's some opportunities out here. If you've not engaged with it, if you haven't thought about it, this gives you some idea of what kind of monies may be available to you if you've not been doing some analysis and some studies on the data and the patient services you're delivering. And this came as a result of health directors asking me, Mike, how are we going to make it with ACA? It looks like we're going to lose some services. Well, I'm concerned with our revenue, but this kind of portrays really what's going on. I'll use one here in scenario C that actually can show you what a county is doing actually with the bringing on a provider such as a RN or APRN and or a physician. But in County A here, we said this is an example of a county with real data that had uninsured back when Kentucky was doing a study of expanding Medicaid back in 2012, 2013. They did a study to see where the uninsured is by county. So this county in particular had an uninsured number of 10,000 its population uninsured. They further determined that of that uninsured, there would be roughly 5,120 that would be Medicaid eligible, and another 5,000 that would be qualified health plan eligible. So again, that population uninsured was based on populations under age 65, all population under age 65. But of that, you can see about 50% in this county was Medicaid eligible, and about another 50% was qualified health plan eligible. So as of today, or as of 2/27/2014, this county had 2,893 it was able to enroll. The county had 2,893 that was able to enroll into a qualified Medicaid plan. In addition, they had 840 as of 2/27 enrolled in a qualified health plan, private insurance plan. So what I did, assuming that we had County A with a RN as a primary provider type, it said that with no additional infrastructure perhaps, we could see those patients and bring in revenues of $107,000 if I just did an EM 212 one time in the whole year for each of those patients. Because you remember the Medicaid revenue is a full revenue too. It's no match, as you heard Commissioner Kistner say, there's no match on that expanded member, and that's what these are. These are expanded member enrollments, those under age 65. So if the nurse could do what she can, a 99-212 visit, she could bill in and bring in $107,000 of no tax, no match Medicaid revenues. In addition, Medicaid, they could also do a preventive visit with a trained nurse. A trained RN can do a head-to-toe preventive visit. In doing that, it's about $100 that Medicaid pays. So that's another $289,000 that could be brought in. So in this County A as an example, there's about $400,000 of new revenue for perhaps even an existing infrastructure that that county may have at the health department. And again, this assumption can also be saying, well, if I don't see all the patients, what if I saw only 50% of the patients? And I've done a breakout assuming 50%. So it shows the revenues are smaller, but again, it still shows there's opportunities with an RN provider, that there's opportunities to actually bill for services because members are being enrolled, and that's a job that you all work with today, getting people enrolled through the Connect or through some other source. The value of that, getting people into the system, is potentially revenues available to you. Again, that no match is a 3-year no match, I pointed out here too. The match is, its match is way from 2014 to 2016, so 3 years. It starts in 2017 at 5%. Another scenario was we used a County B. County B was a county that had a provider type, a mid-level, a practitioner, and or a physician. And obviously with those provider types, they can do more than just Medicaid. They can do also insurance. So using this county, again, another county, real data with it, 10,000 uninsured under age 65. Medicaid in that county was determined to be about 50%, and another 50% would be qualified for the health plans. Today, as of 2/27, there was 4,100 enrolled. So that county had 4,126 of its 5,200 target enrolled, or about 79% as of 2/27. So through the health department, if they're able to capture those patients and do a service, which they can do a preventive visit, again, $100, that'd be $412,000. If they could only see half of those patients, again, just hypothetical half, $206,000. No match. Medicare rates of pay, no match on those. For private insurance, because now they're eligible to bill the QHP, the Qualified Health Plan, there's opportunities also to receive $107,000, or roughly $90 per visit, or 50% of that $90, or $53,000 for those 1,199 that are enrolled as of 2/27 into the Qualified Health Plan. And that was a county, again, with a primary provider, RN, but also with mid-levels and physicians. Keep in mind, in addition to the primary, in addition to the preventive service that could be billed by, by these provider types, there's also the opportunity to bill outside the preventive services and receiving additional reimbursements. So these are bare minimum, so far they've given you our bare minimum opportunities. That's saying just one visit of each of these top preventive services. But there's other things that can be done in these examples, all these examples. So these are minimal revenues. County C, a third scenario, shows the RN as the primary type for that health department. And they have actually considered adding a physician and or a practitioner. So there's truly a county out there today that's saying, I have RNs as my primary type in this county, but what if I added a physician and a practitioner? Well, here's some of the data. In that particular county, they had 18,000 uninsured based on a study. Of that, roughly 52% were Medicaid eligible, 48% qualified health plan eligible, and as of today, that county has enrolled 5,615 into the Medicaid plan. With that said, if performing services to 100% of those enrollees as a preventive visit only, they could generate $561,500 in a year's time for a single preventive service to each of those members. Again, baseline. They only saw half that amount, of course. For insurance, since there's 2,854 enrolled to the Qualified Health Plan, they can also reach out and get some of those services as well. So in this, again, if it's 100% seen, $256,000, and half that, $128,000. Again, these are just enrollment data as of 2/27. These numbers are obviously going to increase. Medicaid will continue to increase, even the QHP will continue to increase. But Medicaid probably, as it's shown here, it's probably about 80% of all the 75 to 80% of all enrollees are Medicaid, enrolled into Medicaid. But in these three examples, you can see that there's opportunities with both just an RN and a physician practitioner. And the third one was essentially the same thing because it was a county looking to do that and how they could change their financial situation by getting involved. And how important this is, as Commissioner Kitchener pointed out, and as Dr. White kind of pointed out, things we're working on to even enhance revenues further and more than just what we've been doing, is that there's ample opportunities to do this because you guys are seeing patients. You've had uninsured patients for years you've seen without a payer source for those folks. As a sliding fee or no fee at all. So here's some opportunities to take advantage of by enrolling folks into the health plans and then seeing that member that you enrolled into the health plan. And also opportunities to coordinate across within your county with the FQHCs, hospitals, primary cares to serve patients and do this type of reimbursements and revenue generation. You have to understand, guys, here's the thing. Why it's so important that this be followed today as a health department is that our state money is declining. I heard earlier somebody said there's some ACA impacts. There's expected to be ACA impacts to health departments with state funds, okay? There's federal grants that are going to go away. Or greatly reduced. So the days of grants to assist you with your clinical services, those are going away, or at least being reduced significantly. But as you can see through this diagram, through these scenarios, there's opportunities out there for you to be able to bill and receive monies that you never got because these were uninsured patients and you were seeing them. So here's opportunities for you. So by waiting, it's not to your advantage. Commissioner Kitchener said something about competition. So yes, you do have FPHCs want to compete and take these members. You have primary cares want to take these members. But these are probably folks that you all saw previously, know these patients, and with sometimes some small investment through a practitioner or a physician, what you can do with some revenues, but also what you can do with patient care. But it's also the coordination of that care that's needed to make this work as well. So care coordination of the patient. Yes, Jim.
Mike, I have a question. In County A with the RN provider,
Yes.
I guess I'm hearing two different things and just need a little bit of clarification. So with an RN, I'm thinking, you know, the type of service that we have traditionally provided are well taught examinations.
Mm-hmm.
Now there's, I guess, one thing I'm hearing is that we can't do those unless we get the blessing of the primary care provider because there's the whole issue of the medical home, right?
Care coordination.
Yeah. Okay. Which we're not, I mean, in our
But
community.
these are adults. Remember, these are basically adult men. These are the under 65.
Okay.
Under 65, where a lot of these are going to be measured, Commissioner Kistner saying. But the RN can do with training. That RN, if you're not trained, they can be trained to do a complete head-to-toe visit with an adult male.
Is that training coming back? Because we haven't had one for a long time.
I know I did one in spring, and I don't know,
That's the women's health. She's talking about
Correct.
the adult physical.
Oh, the adult physical. No, that'll be something that we'll have to reinstitute if people are interested in doing that. Right.
Hi. Can I ask a question, please? This is Denise from Hopkins County. Hi.
Hi, Denise.
My question is, I have increased my APRN services because I felt like that would help with reimbursement better than RNs with the ACA. But what you're saying, I'm concerned about it because you're saying now that we could start doing adult physicals again and receive reimbursement for those. But isn't this a lot like where we were doing EPSDT physicals and we were getting them done, and now we're no longer allowed to do those because of the MCOs? So I'm afraid if we get into this in a big way, that the same thing that would happen that happened to the EPSDT physicals. And I still feel like my school-age population from K through 12 is now not receiving their EPSDT physicals when we were doing those and covering that well. But I feel like this is almost the same thing with adults, that we're going into doing the adult physicals, the preventive physicals again. What's to keep, in a year if we hire and get into this, then we're told, no, you can't do those in the public health departments again. That's the MCO's responsibilities. The other thing is, if the contract through public health is preventive, what if these are sick people do, and you're saying we can kind of contract some of this on our own? How does that work when we are, when the contract is through you all as preventive? Just a couple of concerns that I have. I'm not against doing this, but if we do it and get into it in a big way, I don't want it to be just pulled back in a year again. Does that make sense?
Yeah, I think I got most of it. So if I start answering a question that wasn't there, y'all help me. The whole idea of the EPSCTs was an attempt to try to get to be some coordination. And it was hoped that we call the family practice doc, the primary care, or whoever it was, and say, we're going to do this EPSCT, we're going to be sending you results. That was going to be seen as a positive thing. Obviously, like you said, that was not seen as a positive thing. And so now what I think, now that we've done this for a year, I think now is when we as DPH go to the MCOs and say, have you gotten these EPSCTs done? because if these numbers are dropping, Medicaid's got a level that they're supposed to be reaching. They're supposed to be doing so many EPSDTs. If they're not doing them, then I think that's when we go back to the MCOs and say, look, we've got people that want to do these, and they're not being allowed to do them by the primary care. So I think now that we've got some information, that's when we step back in and say, look, we had a good service that we were offering our students, our younger kids, and I think we can have some control over that. Now, do I know that for sure? You know, I don't think any of us in the room know anything for sure, but I think we've got some ammunition to show that we had a system, and we just need the pediatricians and the family docs to be more cooperative with us, because if the kids aren't getting it done, it needs to get done, and if it needs to get done to the health department, then we need the MCOs to support that.
Well, we've been doing sampling on some children, and I know that it's not being done, but that's a personal issue for our county, so, you know, that may not be true for everywhere. But anyway, I'm sorry, I didn't mean to interrupt you.
No, that's fine. So I would see that the same thing with adults. If we get y'all doing some adult care, and someone tries to interfere with that, well, we've got some examples now to show, no, we do provide a service, and it's a service people aren't going to be getting otherwise, so they need to be taken care of by the people that know how to take care of them. So I don't think that's going to be a problem.
But you do see where my concern is, because it reminds me almost of the EPSDT program that we were very much encouraged to get into in a big way, and we did. And we did it well. And now that's been taken away from us, so I'm willing to do these adult physicals and use the APRNs and everything that he told us, but I don't understand how that's different than the EPSDT program just with adults. And what's to keep the same thing, if we build an infrastructure to do this and we start doing it well, what's to keep the same thing from happening, to just be told in a year, now you can't do those anymore as part of preventive because the MCO needs to be providing that service?
Well, and I think that's where I'm hopeful that we can take the information, the data that we have now, to show that those kids aren't getting the care, and we need to go back to doing things the way we were doing them, as long as we keep that loop of communication open that Commissioner Kissinger was talking about.
Okay, thanks.
Dr. Leach?
Yeah, let's talk about hiring a physician to work in a health department. I think if you get the right kind of physician and you put them to work doing the right kind of thing, the way the state did back in the 60s, when something the size of Barren River or Lake Cumberland was a big enough area to keep a doc busy doing public health, you got something. But I caution you to get in the direct clinical care business with a medical doctor. You better get somebody to do the business case, because your malpractice is going to go up, and these guys are going to want lab data, and they're going to want to cover their flank for being accused of missing a diagnosis in a physical. There's several of us that were in the primary care business and got out. And somebody really ought to study it. I have a fundamental disagreement with this push to get into medical direct care, because I've done them both. And I'm one of the few that are involved in this stuff today. And you better get accustomed to feeding big old gorillas if you're going to put doctors to work in county health department.
And I've done them both too. So
You've done public health?
No, I've done primary care.
Well, I've done public health and this.
Okay, no, I've not done both.
And
I don't think it's going to be the right thing for every place. And I understand that, but I do know that there are other people in the room that ask for this information because they are interested, and that's why we're presenting it. These were things that people ask us, so rather than us just call that one health department director back and give them the scenario, it makes sense to show it to everybody, and that's what we're doing today.
But the lady from Hopkins County is asking a fundamental question. After the dance is over and all of the money is gone, what do I do with the 30 people?
And I hope I answered it the best that I knew how to answer that. Randy?
And I may have missed it, but I'm a little confused on like the adult physicals that we're talking about. Are you saying, are we going to have to become a medical home for these new participants in order to do that? Because I guess I would see the medical home as being the place that those adult physicals are going to be done. Or are we saying, are we just trying to partner with the physician saying, if you don't wanna do these, we will do them?
Yeah, and I think when I saw this paper today, I'm thinking more the well woman visit than the adult medical home. That's something we can pursue, the adult physicals. That's something we can pursue if anybody's interested in going back to that. Like I said, when I first saw this paper, I'm thinking the well woman visit and the enhanced nursing training that I was talking about that we had last year. So that was more the direction I'm going. And I think you're right. I think if you've got a primary care doctor's card name on your card, they're going to want you to come to them. But I think there are some well woman visits and some things that we can do. Yes, Russ?
If you were gonna go get approval for this to be done, how long would that take?
Approval for?
For us to be able to get back into doing those kind of
The
visits?
EPSDTs or the adult physicals? That would, Joy can probably help me better than that, because she was here back when, I was not in charge of doing the adult physicals. I was just doing
Is it gonna
the
take 6 months? Is it gonna take a year to get an answer? Or?
To get an answer, well, I don't know that there would be, the answer would be, number one, will we have people trained, which I would say would take at least a good 6 months. But number two is, what's the primary care doctor going to require of us? And so that would be a question that I'd have to ask. But I can, if that's something y'all are interested in pursuing, that's not in our driver's manual, because I just didn't figure y'all were interested in getting back into that. But if somebody is, we can inquire about it. Until you find out. Okay, all right. Well, then we'll need to find some answers out for you, because I do respect the fact that you don't want to go out and hire somebody unless you absolutely know what you're going to be able to bring back in. I understand that piece, but we can inquire about that.
Are those numbers just women?
No, these are,
No.
these are the population of everybody that's 65, or under 65.
So they're-
People that enrolled, they were under
So
65.
So if you're looking at doing well women visits, you would want to look at
Yeah, you'd have to look at,
just around. These are all just round figures.
Dr. White, this is Denise again. So my understanding, because my background as nursing director, is these were the same physicals we were always able to do with either an expanded role registered nurse or an adult trained registered nurse that is just like the EPSDT training, but it's for doing adult health, and it's using the same forms, the CH3 and 4 or 13 and 14 that we do for the children, but this is the adult version. And so there's 3 ways to do these adult physicals, either with an APRN, with the expanded role registered nurse, or with the RN that's trained in the adult version of the EPSDTs. And we were always able to do these, we just have not been paid for those. And that's the same types of physicals you're talking about, correct?
That's if you talk about getting into the adult
Right.
physical services, yes.
Right, okay. Thank you.
Okay. Questions?
I just had a comment.
Go ahead, Sam.
About the insurance. I don't know if anybody else bills insurance very much, but when we bill insurance, even for our APRN visits, we get about a 10%, we get paid for about 10% of what we bill.
You get for each visit, or of all the billings that
Of
you
all
do?
the billings.
And why is it being denied?
Different reasons, but insurance companies just don't pay health departments, and I've heard that from several other people that have tried to bill insurances. So I don't know that. Lots of times because of RNs.
Connie, we collect, but I have to be, as a physician, enrolled with the United Healthcare or whomever. That may be where the problem is.
So they're billing it under the physician code, right? Yeah, and I would invite, and I'm going to regret that I live to say this, but I'm going to invite, if you've got a denial, let me know, because Lord knows in 20 years I dealt with plenty of denials of I brought 2 boxes over here to Medicaid one time, and at $85,000 they owed me. Now, you have to bill a lot of Medicaid to be out $85,000. That's not how much I had billed. That's how much I was going to be getting back. And I went through every one of those claims to figure out why they were denying it. So we need to find out if there's a pattern, because if there's an insurance company that says, I don't pay health departments, then we need to find out why, and we need to fix it. And if it is involved, you need to have a physician or an APRN that's on their registry, then we can fix that. But we need to find out what they are.
What we found was it took more time and trouble
stay, to fill out the applications and keep everything current than we were actually receiving back from the insurance company.
Okay, but you're only getting 10% back. I mean, can you figure out how much you would have gotten back? It doesn't have to be that hard. I guess that's what I'm telling you. But I mean, unless I know the particulars, I can't really answer that question. But I would love to work with you on that.
Okay.
Okay? Yes, ma'am.
When Commissioner Kistner was talking, he said, look at your EPSDT list, check to see when the last well child is and contact that person.
Mm-hmm.
But we know that we're supposed to be working with if they have a primary care physician, or a medical home, we're supposed to be working with that. So should we not have taken anything does he not understand that we can't do that, or was he just saying, do it on our own just for the good of the child?
No.
We can't collect that, but he said we should contact them and bring them in. That would close that loop. Well, we were told that we were supposed to work with that medical home.
The EPSCD outreach, unless I'm just completely disillusioned on it, the EPSCD outreach is different than actually doing the EPSTT exam, right? So your outreach is, let's call Dr. Who's It and get you an appointment. That would be your outreach. And then if the patient says, I don't want to go, I can't take off from work, or whatever the excuse is, then there'll be an attempt to call this provider and say, look, we can get this done at school, the kid's going to be there, the parent can't take off work, you're not going to get the visit anyway. That's the mentality I'm trying to explain to the providers so that they'll understand. Because like I said, if their EPSTT numbers go down, then Medicaid jumps on them for not getting them done. So that's what I think we can use as our ammunition is, look, we've tried to do it this way, and we've got kids falling through the crack. That's not how we provide care for people. So let's come up with a different, better way that we can make this work. Because I think in a lot of places, this was working well, and in an attempt to try to make things work even better, we've come up with a problem that we need to fix. Randy?
I mean, I think for several health departments to survive, they're probably going to have to explore, being committed to these areas. And I guess I would ask it, can we collaborate, CADA and DPH in some way with sitting down with these MCOs to try to find out what we can do together? Because we do have a contract with DPH, so it just makes more sense that DPH, is contracting with the MCOs that we go about it in that manner. But we certainly would like to be at the table with you to explore the, different options that we have. I mean, I see it as being an easy thing for them to give us roles of participants who have not had a preventive, exam in over a year, and for us to explore that and reach out, and even if we get them set up with another provider, it's beneficial for the MCO.
If you get paid for doing it, and they save money having it done, I see no reason not to do that. So that's why we need to know. That's why we came up with the driver's manual. That's why we want, if you've got ideas of things you want to try to work on, we'll help put everybody. I mean, I think it would make more sense if 3 people went at one time instead of 3 different people at 3 different times. I mean, that's where Dr. Mayfield is this afternoon, is the MCOs, CMOs meet once a month with Dr. Langfeld, so they're meeting this afternoon. So we've got an opportunity to, in front of all the chief medical officers of all the MCOs, say, we got this idea. We want to talk about this. There's a place for us to do this on a monthly basis. We just need to know what kind of things you are willing to do, or do you just want to walk up to them and say, like he said, what do you need done? Tell us what you need done, and we'll go out and see if their health department's willing to do that. We've had one person came to us and said, we want all the health departments across the state to do this for us. And Scott was in the room, and when they said that, it was like, whoa, we can't tell you all the health departments in the state are going to do anything. I mean, that's not our role. It's something we can offer, and the ones that want to do it can do it. So we're very cognizant of the fact that everybody doesn't have the same situation. So we do not volunteer y'all to do a statewide program. So that's a conversation that we need to have, probably not here today, but we need to have that conversation as to how you want us to go forward. I'm sorry, Russ?
I'm one of the home health, or I have home health in my health department. And I, for one, would like the state to be with me when we can talk about the contracts that we're going to have with these MCOs, because I don't think any of us are getting anywhere with contracts. Mike, what are you hearing? Are you gonna be willing to help us or not?
No, I will do what we have in the past. You know, we've not had the contract, it's your all's contract, but we've worked with you guys, and if you had some concerns, we've helped to work with you, to share information with you, for you all to work with the MCOs. But whatever the commissioner wants to do in that respect, but what we've done in the past, I can understand we could continue to do that unless there's a, you know, change here in our department that says we won't, but we've been very supportive of the home health.
The cost settlement language, though, has been, you know, it's not been something we've negotiated individually. It has been something for home health that, you know, it has been there with Medicaid.
And I think, remind me though, guys, didn't we write some language, did we craft language maybe a year ago when we first were, or 2 years ago when we were first getting business with the MCOs for home health? We used language, I believe, that would still be the same language because it referred back to the regulation for home health, Medicaid regulation for home health. And that would be one I would encourage you to use that language, because that does set the tone for local health departments to be cost settled for services they provide. So, but let us know where we can help in other ways.
Mike, what's happening with that, when I sent those contracts for home health, the Passport, and Humanist, they're just ignoring that. I mean, Passport was good dialogue, I have to say that with them. Okay. John Burris, Vice President.
Right.
But with Humana and Anthem, we're kind of running up against a brick wall with that. I added that addendum to the contracts for Whitney County, and they haven't signed those or come back. They're calling the referrals for those patients. They want to give us $87.15 a visit, which is less than half of our cost. We're not going to accept that.
Yeah.
So we're running into a Medicaid situation where we've outreached and we're bringing these people into Medicaid, but they're not going to have home health services because the other home health agencies won't accept that either. We were their stopgap, and they have not signed our contract and sent it back. But yet they want the patients to come and they want to pay us what they want to pay us.
You still have your Coventry and WellCare renewal.
Coventry and WellCare are doing fine.
Yeah.
This is the new one.
Yeah.
Okay. Well, we've had a lot of fun negotiating with them, so we're on the phone with them a lot. So after this meeting, let's you and I talk about what we need to do next with that. And I know we're not going to have an April meeting, so between April and May, if y'all would either contact your CADA executive people, if you're more comfortable with that, or contact me with ideas, questions, things you'd be willing to do.
Not having an April meeting.
I thought April and that during the CADA meeting, are you not having a CADA,
No,
KHDA meeting?
No, CADA is in April. CADA will be.
Oh, that's right, I just got the email. So we
Be here on the 22nd,
Okay.
be April 22nd.
Well, then, before April the 22nd, let's corral all these ideas and see if there's something we can move forward with. Okay? All right, let's move on, let Joy get started, because I know we're running out of time.
I can email them.
Okay.
I just have 2 updates.
Okay.
We're running late.
Okay? Kathy?
Let me ask one quick question here.
Yes.
As we're being, Mike's statements here with federal grants going away and the different things here for us to be more creative, we also have to be mindful that a lot of our regs, or a lot of the programmatic guidelines for the programs that we're following, like cancer screening, all this stuff, those were formulated when we had, a lot more grant funding and a lot more, activities to do. I know we've talked about this before, about paring that down to what is the minimum required for this to do with this funding. So I think, now more than ever, we need that focused attention on that, Joy, for the women's health, with family planning, with the breast and cervical cancer program. Again, as we see grant funding going away more and more, and we're shifting our business models, the guidelines, our programmatic guidelines, have to adapt as well, because we can't do, guidelines from 15 years ago in today's financial climate.
And I know Dr. Mayfield is going in 2 weeks, I think, to CDC with Dr. Langfeld, the medical director. I know she's met with Dr. Frieden and talked to him about this very same thing. We talked to the ASTO president about it, who said he was going to get with the HRSA people about it and the CDC people about it. We don't pass up an opportunity to not say, this is more than people can handle. Now, if you're looking at your breast and cervical cancer program, 75% of these people are going to have Medicaid. And when they come in for a well woman visit and they've got Medicaid,
you don't have to collect 120 daily elements to see a Medicaid patient. So that will be some help, if that's any help at all. Dr. Humbaugh, you have any bugs and disasters?
Just had a couple things. First, I wanted to thank the executive committee for providing us an overview of what, and especially Georgia, providing us an overview of what happened at your strategic planning meeting, and our meeting is soon. Yes.
So we need now a representative of DPA
Good.
for our strategic planning committee, and I
Okay.
sent out, Brandon now has the work group, so.
Okay,
we need
great.
DPA participation.
Good. Did your membership get your slide set?
Yes.
Okay. Could we also have that, or
Yes.
did you send it to Brandon?
Yes.
Okay. Excellent. Thank you. Second is, unfortunately, the hospital preparedness grant, we just got the RFP for that this week. It's been reduced by 39%. We knew it was probably going to be on the line for 30%, but they also did a new funding formulation, and at that time, that also hurt us as well. So we're going to be looking at how to restructure that program, but to try to keep some of the capacity that we've been able, the great capacity we've been able to build with our healthcare partners. It's the smaller of our two preparedness grants, but we're talking about losing between, around $1.8 to $1.9 million. When you lose that much, you have to look at, fundamentally how you're going to redo the program, and still prioritize what your goals are for that program. So more to come on that particular issue. Thank you.
Gary Faulkner wants to make a comment about accreditation, state accreditation.
Morning, just wanted to update you. We have made the decision at the department to delay filing for our application on accreditation, and basically for two reasons. One is the Kentucky Health Now initiative that the governor has announced, and we want to take our state health improvement plan, we want to incorporate those. We also want to take a look at our strategic plan and make sure that they're melded together. The other side of it is staff has released the 1.5 standards, and we think that it's prudent to take a look at those and actually do our filing under the 1.5 standards instead of the 1.0 standards. So just wanted to kind of give you an update that that's where we're at. We're still working on accreditation, but we've kind of slowed the ship down a little bit in order to address those things so that when we do submit it, it will be as solid as can be. Any questions? Thank you.
I think that's everybody. Any other questions? We appreciate your time, and just glad Commissioner Kistner could come. Yes, Randy?
Are there any updates on the budgeting process yet?
The Senate has it.
Timelines or,
The Senate has it.
for training or anything of that nature? I'm talking about.
You're talking about local
planning budget, yeah.
Oh, I'm sorry. I thought you were talking about the mother budget. Okay.
April 9th, guys, is, and I speak because that's what we agreed to, so I guess that's official now, right? April 9th is going to be the training for the budget templates on how to, it's what we call the technical skills needed for the budget inputs. So that's April the 9th. So we'll get that communication to you. So hold that, because that is the date, but I want to make sure that that's not changed. But my agreement with our budget office was April 9th, so we've got things held for that. So I'm just surprised y'all not seen that communication yet. So.
Any other questions? Okay. Thank you, Scott.
Okay, thank you very much, Commissioner White and Deputy Commissioner White, Deputy Commissioner Humbaugh, and everybody from DPH. Thank you so much. I know, Georgia, did you have another announcement here? You want to come up here, please, and another announcement about the strategic planning process as we move forward?
Okay, I'll be available right after this meeting to discuss, as long as anybody wants to, the Public Health Institute. I brought copies of the bylaws for that. where we are in the process with that. And also, I want KHDA needs to figure out a way they're going to elect or an appoint or whatever directors to sit on that board. 2 where the population would be less than 50, 2 where there's 50,000. We don't have any that little, do we? Maybe close, but not that little. 2 where there's a population greater of 50,000, and 1 from an independent health department. So there are 5 director positions on that board, and then also automatically the president of KHDA and the president of KPHA, which could possibly be a director, not necessarily, but so there's a lot of director representation with that group. So there will be a meeting of the actual everybody that has been invited to be a part of that group and where we are on the 31st. I can send you the information for that. That'll actually be at a Foundation for Healthy Kentucky's office in Louisville. How about that? So that's the 31st, and you're welcome to come to that. But today, I would like to talk to anybody from KHDA, albeit on ITV or whoever's in this room, about, I want to answer any questions that you have and share some documentation with you for that. That's it.
Okay, so how long will that take? I mean, do you want, so we'll go ahead and adjourn, and then
Yeah.
you want to do and whatever. Okay. Okay, then, so I want to thank everybody for anything, any parting comments, last thoughts or anything here? Dudley, yeah, update on Dudley. Do we have any information about Dudley? I know he's been in Jewish Hospital. Any updates that anyone has? Okay, haven't heard, so, okay, we need to find out about Dudley then, so see his status, because I know he's been ill, he's been in the hospital here, so thoughts go out to him for sure.
He's been very ill, and I haven't heard that it's changed.
Okay. Any other comments or questions? Okay, so those that want to stick around here for the Public Health Institute, hang on ITV. Other than that, I need a motion to adjourn KHDA. Okay. Thank you all very much.